would enter the relative contraindication of T type. Now is the last question for exam. So if patient needs a T, but for esophageal pathology, T is contraindicated. So how do you monitor? What are the options available in pro to check the harm?
Cardiac output monitoring.
No, to check the assessment of the patient has come for a mitral valve surgery. The patient has got a esophageal pathology, which is absolute contraindication for T. So what are the other options you have where you can still assess the mitral valve but not using the TUE? Transvarsal later on. Epicardial. Later on.
One question to Dr. Mona Lisa. A patient with is coming for emergency CVG. Surgeon is doing surgeon is also rushing for pump because in emergency CVG they don't go for off pump CVG usually. So will you go for there or not? Yes, sir. The patient is running, the surgeons are running for going on pump. At that time, will you get time to give the T probe? Because they will come, they will give the incision, they will tell you, give heparin. At that time, how will you give the T probe for those patients? Is it possible? Is it required?
It's not absolutely required now, but if patient is not, again, if the patient is not high risk and it's low risk surgery, then if
emergency surgery it is emergency CVG. You go for T or not? The question is open to the forum.
Yes, I think that's true.
Yes, ma'am. We have to give them as well. It will take few seconds.
It will take few seconds. So
yes. And it will give enormous.
So we also rush with the surgeon. Surgeon will rush. If the incision, I will rush the surgeon to put it.
We will ask to put the probe and then give apparatus. I have another question.
That is the answer. They will put the probe and they will start.
Any autonomic instability plus one increase nothing.
Exactly.
Autonomic instability. Imagine space plus increase.
I have a question to both of you that we actually have one T probe and we have two OTs. And in one OT we are having a bad case and another OT we are having T. So I have to give one. That's a practical scenario we are facing there. What do you think? In which patient should we give? Valve cases, yes. And if it is a valve with any critical high risk that ma'am and sir has said, high risk CABG with a very prone to have hemodynamic instability, we have to see the valve status first before giving heparin and we put the T to the CABGs also before giving. Thank you.
Thank you.
Okay, great discussion. We'll move to our next session. That is a very important topic. Cerebral oximetry should become a standard monitor during all cardiac surgeries. In some of the countries, it has already been a mandatory, but not in India till now. So to moderate this session, I will like to invite Dr. Ravi. Sir, please come and initiate the session.
Cerebral oximetry, that is a near infrared spectroscopy, is available for last 10-15 years in the market, but Still in India, it's not freely available. Some tertiary care centers is having it, but there is no routine things. But let's see what our speakers say today. So I would like to invite for the pro, Dr. Oishisa.
Good evening, teachers, respected teachers, my colleagues, and my seniors. I am presenting I'm Dr. Oishi Shaw from R.N. Tagore Hospital, and my topic is cerebral oximetry. NIRS should be a standard monitor for all cardiac surgeries, and I am talking further motion. It gives an early real-time detection of cerebral hypoperfusion actionable before injury. NIRS gives continuous bit-to-bit information about regional cerebral oxygen saturation at the frontal cortex. Multiple studies have shown that cerebral desaturations often precede clinical hypotension or low pump flows by several minutes. When desaturation occurs, we follow a systematic approach to detect it by Andre Denon. As we can see, this is the algorithm we follow. Cerebral saturation, bilateral reduction by 20% or one-sided reduction by 20%. We verify the head position to see whether there is any thinking in the carotid arteries or any excessive turning of the head. If by making the head neutral, there is improvement of cerebral saturation, it's okay. If there is no clinical improvement, then we monitor the mean arterial pressure. If there is any hypotension, we have to treat the etiology of the hypotension accordingly. If there is drop in saturation, then we have to find the etiology and treat it. If there is any alteration in PaCO2, we have to correct the model, whether it is metabolic or respiratory accordingly. Then we have to check for the hemoglobin. If it is less than 7 to 8, then we consider blood transfusion. We have to assess the cardiac function and venous saturation, mixed venous saturation. We can do so by hemodynamic and echocardiography evaluation or cerebral oxygen consumption or intracranial pressure. We have to see for the convulsions, hyperthermia, or cerebral edema, whether it is present or not. For that case, we have to also monitor for hypothermia, You have to give anti-epileptics medication to reduce ICP if there is cerebral edema. And we have to do the echocardiography evaluation to see the cardiac function. These are some of the studies I found which shows the pros of using NIRS. The initial being, it was published in Cardiothoracic Anesthesia, Respiration and Airway Journal. It was cerebral NIRS in adult heart surgery, a systematic review of its clinical efficacy. The conclusion was, it was an adult study, and the conclusion was NIRS in heart surgery as a brain monitoring device seems interesting. However, NIRS has to be investigated more rigorously to prove its clinical utility in cardiac surgery. As Ravi sir said, here we are not using that much. Prognostic value, another journal was a prognostic value of perioperative NIRS during neonatal and infant congenital heart surgery in adverse in hospital clinical events. Here it was done in pediatric age group neonates, and it was done on bypass for all bypass surgeries. And the conclusion was, at bypass conclusion, 10 minutes of muffing does not adversely affect the cerebral or renal NIRS. Left and right cerebral NIRS are equal, so biparietal cerebral NIRS monitoring is probably not warranted. Perioperative cerebral and renal NIRS readings, respectively, below 45 and 40% may lead to ECMO on death, or renal NIRS below 30% may correlate with prolonged ICU stay. Cerebral NIRS and lactate levels have shown a strong inverse correlation during the first 6 postoperative hours. The next study was a multi-site NIRS which predicts elevated blood lactate level in children after a cardiac surgery. Here also we found a conclusion of average cerebral and renal saturation of regional saturation less than 65% as measured by NIRS predicts hyperlactemia in acyanotic children after congenital heart study. Hence, this non-invasive continuous monitoring tool may facilitate the identification of global hyperperfusion caused by low cardiac output syndrome in this population. Another study was the role of intraoperative regional oxygen saturation using NIRS in prediction of low output syndrome, similarly in pediatric heart surgery. Here also, intraoperative NIRS provided an early warning sign of hemodynamic and metabolic compromise, enabling an early and rapid intervention to reduce the life-threatening complications. Next, it also helps in interventions guided by NIRS can reduce the neurocognitive complications and perioperative morbidity. Randomized trials and meta-analysis show that when desaturations are treated using standard algorithms, patients have fewer cognitive deficits, shorter ICU and hospital stays, and sometimes few major organ complications. This suggests NIRS can translate into patient-centered outcomes when paired with an algorithm, just like I showed. Some of the studies were optimizing cerebral oxygenation in cardiac surgery. A randomized controlled trial examining neurocognitive and perioperative outcome was done. The conclusion was a targeted therapy to optimize cerebral oxygenation was associated with better memory outcome in a group of cardiac surgical patients. Some aspects of the protocol other than desaturation duration and severity contributed to the observed neuroprotective effect. Another study was a cerebral oximetry in adult cardiac surgery to reduce the incidence of neurological impairment and length of hospital stay. This was a prospective randomized controlled trial. Maintaining cerebral saturation above the baseline reduces the time spent in ICU and thus may improve the long-term functional recovery. There was another study. Similarly, the value of cerebral and somatic NIRS with an integrated tissue perfusion monitoring strategy in cardiac surgery, a prospective pilot study. Here it shows that NIRS cerebral oximetry represents a useful tissue perfusion monitoring tool. A cutoff value of less than 22 for a single hemisphere and 32 for bilaterally correlate with hyperlactemia and may serve as an alarm from prompt action. It also has benefits which are used in high-risk cardiac surgical patients. Though we can use in all patients, but these are exponentially used in aortic surgery cases, carotid disease patients, those who have bilateral carotid stenosis, redo or supraortic arch cases, complex congenital cases which are done on CPV, Then diabetes mellitus patients, as they have microvascular complications, so NIRS will predict the hypoperfusion much before we can detect it by lowering of the saturation. Similarly, in hypertensive patients also it is of help because in hypertensive patients the balostat is set at a very higher level. So before we can detect the hypoperfusion, NIRS might help in detecting that. In cases with anticipated extremes of flow or pressure or aortic manipulation, cerebral oxygenation may abruptly and unpredictably change. NIRS adds a safety layer when embolic or hyperperfusion risk is high. For these kind of cases, cerebral oximetry is not at all a luxury, it's a necessity. And low incremental invasiveness, easy integration into the workflow, and low risk. NIRS is non-invasive, quick to apply, provides continuous alarms and numbers, and can be used during the all phases of cardiac surgery, induction, CPB, rewarming, and post-op. No additional risk, yet it gives a live window to the brain. Now, there are certain points which my opponent may say that RCTs are inconclusive. Mostly because this NIRS studies were a single center study were performed. So some of the meta-analysis, however, have shown it has constantly reduced cognitive dysfunction and shorter ICU stays using NIRS algorithms. Because of the lack of uniform standardization, there is lack of evident data in single center studies which may reject this, but we have to standardize the protocol rather than rejecting the monitor as a whole. Then she will say devices differ and thresholds may vary. This is absolutely, but we don't depend on absolute values. We will rather depend on the cutoff values or decrease from the baseline. Like we can say 20% drop from the baseline in a cyanotic patient, or a drop below 50 to 55% in other patients. This trend is reproducible across platforms. Like in pulse oximeter we use, there is 1 to 2% variation in different brands of pulse oximeters also, but for that we don't reject the pulse oximeter. Then there is another risk of over intervention. So for that we are using this kind of a structured algorithm like I showed, the Denold algorithm. The cost is also high. That's a very debatable topic. The cost is very high. But if we can say one patient from post-operative cognitive dysfunction or late awakening or any patient having stroke, that is much less than cost of the monitor. And also it measures only the frontal cortex. That is also a point which might come. But in cardiac surgery, mostly we see the global hypoperfusion rather than focusing on one particular part, though it monitors only the frontal region, but that is the region which is most sensitive to the global flow changes as detected on NIRS. Thank you.
Very good, Joyce, and you have actually quoted a lot of studies. So a lot of studies being done on favor of monitoring, but still I think there is no conclusive randomized controlled trials. But,
There are some, but single
there's a-
sector. We have to do more multi-center.
and a lot of issues are done with standardization. What how we monitor the higher functions, cognitive behavior, and all that. Well, let's see what Dr. Snigdha has to say.
Good afternoon, respected moderators and my senior faculties and my colleagues. I'm Dr. Snigdha and I'll be speaking against the motion for the topic cerebral oximetry should become a standard monitor during all cardiac surgeries. A little disclaimer, I'm not against NIRS, I'm against making it mandatory. Okay, so let's start my talk with a very basic concept that what does a standard monitoring system has to, or what is the criteria of a standard monitoring system? So it should be clinically relevant, highly accurate and reliable, have rapid responsiveness, user-friendly, ease of application, cost-effective, widely available, should interfere minimally with surgical workflow, consistency across patient populations, strong evidence base, have good regulatory approval and standardization, and intra-device reliability. Now, when we search all these criteria in cerebral oximetry, we do find that there are certain limitations. So, the limitations of cerebral oximetry are limited evidence of benefit, anatomical and technical limitation, lack of clear protocols, cost and resource burden, and usefulness varies across the patient. So, let's talk about each point. So, yes, cerebral NIRS definitely detects cerebral desaturation, but there are studies like Murphy et al. They found that NIRS-based algorithms did not improve clinical outcomes in adult cardiac surgery and were not cost-effective. Similarly, Serrano et al. They found that no significant reduction in mortality, stroke, or major morbidity with NIRS-guided care versus standard care. Next is a signal versus action versus outcome gap. What is it? That if there is a NRS saturation drop and the anesthesiologist does something, it doesn't always guarantee that a better patient outcome. So we can say that NRS improves monitoring data but hasn't conclusively improved outcomes enough to justify its mandatory use. Next, coming to the anatomical and technical limitations. So we usually place the probes on the forehead where the frontal region is monitored. The posterior territory supplied by the middle cerebral artery and PCA are usually not monitored. Hence, any stroke occurring over that area is usually overlooked. And next, the probes are very much susceptible to artifacts like skull or scalp thickness, skin pigmentation, probe placement, adhesive issues, ambient light, electrocautery interference. So all these affect the readings and may cause unnecessary interventions or alarms. This is backed up by two studies like Websaki et al. Who found that yes, these NIS probes are prone to artifacts, and another by Edros et al. So he found that NIS frequently miss the true cerebral ischemia. The frontal NIRS only reflects a small portion of cerebral blood flow, and focal ischemia does not always equalize global desaturation. That is, many strokes were localized embolic events, but they did not decrease the NIRS level. Hence, the risk of false reassurance remains with NIRS. Next, coming to lack of clear intervention protocols. So, there is no universally accepted thresholds. We have found several studies defining several cutoffs like less than 20%, less than 25%, absolute value less than 40%. And also, there is no standardized corrective bundle like when there is a desaturation, what do? We try to increase the mean arterial pressure, increase the FiO2, or we try to correct the CO2. So this has been backed up by studies by Vena et al. Who say that while attractive, the NIRS current data do not support the NIRS as a tool to reliably diagnose or prevent neurological complications. Similarly, Thudiam et al. Also found that it does not prove that NIRS-guided management alters the outcomes. Next, a major limitation, that is cost and resource burden. The NIRS probes and the monitors do add to the cost of the cardiac surgery, which are most often a life-saving procedure. Studies from Zen et al. They found that NIRS costs more than $200 for evaluation of benefits versus cost, and underscoring that cost effectiveness is unproven. Similarly, Bachman et al. He found that routine universal NIRS does not seem to be justified regarding its cost effectiveness. Murphy et al. Found in his study that there was no economic justification for mandatory NIRS use in unselected adult cardiac surgery. Hence, it is better to prioritize this in those resource-limited settings and better to fund competing resources because we do have existing standard monitors which address these risks like transesophageal echo, epicardial echo, or invasive heartline, blood gas analysis. All these already guide the cerebral perfusion pressure, the systemic oxygen delivery. So the redundancy versus necessity always remains with NIRS. I have a few studies backing up this. Montgomery et al. He found that NRS trends closely mirror existing systemic parameters like mean arterial pressure, venous saturation, and there are no added predictive value for adverse outcomes, and it suggested that NRS may be redundant during routine cardiac surgery. Renzeki et al. Also found that NRS is helpful in complex high-risk cases. A recent study by Zhong et al., who demonstrated no reduction in stroke mortality or major morbidity, and reinforces that standard monitors are generally sufficient for most cases. Similarly, studies by Green et al., Deshem et al., Subramaniam et al., Harer et al., they all focuses on high-risk CPV patients, exploring how often significant desaturation occurs and how an algorithm responds. Hence, it's needless to say that NRS should be used as a selective or an extended monitor in high-risk cases like aortic heart surgery, complex congenital procedures, carotid disease, or patients having prior stroke. Looking into some few other studies like Yoshidani et al. In 2019 recommended NRS for patients at risk of cerebral ischemia rather than for all the cardiac surgeries. Ortega in their study also found that many NRS corrected desaturations did not translate into better outcomes. With another new study by Khan et al., who found that NRS-based cerebral oxygen saturation monitoring did not predict or correlate with postoperative delirium after cardiac surgery. There's another study where they recommend that their NRS should be used cautiously, and due to lack of standard corrective protocols, it should be a part of multimodal monitoring bundle and not a solo parameter directing management. And here we can see all the guidelines which actually recommend that NRS should be considered or should be used in high-risk surgeries. So we can see that for NRS, the guidelines are unanimous, and we are avoiding, or we should avoid to make it standard, because it would mean that centers without NRS appear substandard, and there is a potential medical legal issue if the NRS is not used. Hence, summarizing all the limitations, we found that NRS has limited evidence of outcome. A good signal always does not improve outcome. It is susceptible to artifacts, cost and resource burden, not equally useful for all cardiac surgeries. There is a chance of overtreatment and potential legal liability, and often found to be a distracting monitor. So finally concluding that yes, cerebral oximetry is a sophisticated and a promising and helpful tool, but considering all the limitations that we have, it is not yet ready to be made mandatory for all the cardiac surgeries. The recommended approach should be for a nuanced, evidence-based, case-specific adoption, and not just a blanket universalization. Thank you.
Very good. Other points. And one thing is clear that it is now recommended for high risk. And when we are dealing with aortic surgery, carotid artery surgery, so it is in recommendation level, but still it has not reached to that level that it should be used in all the cardiac cases. So I think Dr. Arup has to say something. Because you are using the
So then the cost is concerned. So each sensor cost find that cost isn't. Ideally it should be 30. Okay. It's probably not that fine. At this monitor. And my just question for Dagan was students. What are the other monitors you have for the brain monitor? Like NIRS. What are the EEG? Sorry, external oxygen saturation for brain. Yes, trans. Any of you, that should be one thing. If patient is awake, NIRS is low, 30. patient is awake, conscious, oriented, absent, what can be this? Patient, if patient just come to the operation theatre, should always check the NIRS, the baseline, patient is awake and not without any oxygen, the normal blood pressure, normal level. Okay. So you have put the patient on table, put the NIRS. We found that bilateral it's 40. So you have a conscious sodium. What can be the reasons of a low NIRS in a normal patient? Okay, properly placed dimensions. I think those things are all right.
So it's
Skull. There is a very thick skull, very black skin, and very high ambient light. The big things have been mentioned in different articles. These can erroneously cause ONIRS. And sometimes we had a patient with a lead endocarditis who had cross edema and edema of the scalp. NIRS is low pistol. So, edema. Very well done. The final form.
As this monitor is non-invasive in nature and it's not interfering with the surgical field. So if the monitor probes is available with the institution or hospital, it should be used, especially in high-risk surgeries. So it can give an extra benefit along with other monitors like hemodynamics and all. So it can give some extra information. So if you have monitors, better to use. If this cost factor is not a very serious thing. So we are moving to our next session. So that is pulmonary artery catheter should be completely replaced by advanced echocardiography and minimally invasive monitors. So for this, we'd like to invite Dr. Soumi, is there? Okay. So, and both the speakers are here, Dr. Vikrant and Dr. Chung. So, you can come, Dr. Vikrant is for the pro. So you can
introduce yourself.
Afternoon, everyone. I'm Dr. Bode. I'm a candidate PDT in SSKM Hospital. And the topic for today's debate is whether pulmonary artery catheter should be completely replaced by advanced echocardiography and minimally invasive monitor. Now the question comes to mind that is a catheter required anymore in this advanced era? Let's have a look at some landmark studies. There was the first published data was in the year 1987. It was published in the Chest Journal, studying patients with acute myocardial infarction. In this study, 3,263 patients were studied across a period of 4 years in 16 hospitals in Massachusetts. And it studied the mortality associated with PA catheter, which revealed the data that the mortality was higher in PA catheter in the patients in which PA catheter was used. This was taken on a serious account, and an immediate recommendation was advised to rethink about the recommendation of PA catheter critically as well as perioperative patients. Another study was conducted, a randomized control trial, in which elective vascular surgeries were evaluated in two groups, patient with PA catheter, without PA catheter, and it was found that PA catheter made no difference. Instead, it led to higher volume administration in the surgical patients. The famous support trial, which was conducted in 1996, the effectiveness of right heart catheterization in initial care of critically ill patients. This study concluded that there was increased mortality and increased utilization of resources. Again, saying against the PA catheters. And the Pacman trial was conducted in 2005 for assessment of clinical effectiveness of PA catheter in management of intensive care patients. This was also RCT, and it revealed that there was no clear evidence of benefit or harm for PSC use. There are some more evidences which eventually showed that there is no survival benefit, no mortality benefit, no outcome benefit, or no improvement in ICU outcomes. The recent studies also show that there should be a shift to non-invasive tools. PA catheter has very limited indications, and dynamic non-invasive monitoring is preferred. Disadvantage of PAC are mainly mortality, morbidity risk, complications including arrhythmias, infection and thrombosis and PA rupture, misinterpretation of data by the undertrained, and various technical errors regarding false reading. Intracardiac shunts, mechanical ventilation, and valvular dysfunction can lead to incorrect readings. There is a greater learning curve for introducing the PA catheter and reading the data. There are new, less invasive monitoring devices available which can benefit the patient. The new monitors are available with transesophageal echocardiography, ECHO, LIDCO, FlowTrack, esophageal Doppler, ultrasound cardiac output monitor, bioimpedance, bioreactors, and photoelectric plethysmography. The advanced echocardiography has advantage over PA catheter of giving a lot of more data. The data across the PA catheter is limited. It can assess LV function, RV function, preload cardiac output. It has an advantage of real-time visualization, repeatable and dynamic, and there are validated studies for this. The hemodynamic parameters which are obtained by PSI mainly CVP, pulmonary artery pressure, pulmonary capillary wedge pressure, and cardiac output. Whereas echocardiography, as you can see, gives us a lot of more data. Then the most important advantage of echocardiography or PAC is assessment of diastolic function of left as well as right ventricle. And there are guidelines which are validated and established study algorithms for the same. There are some other advanced benefit of non-invasive monitoring with echocardiography in situations of cardiac arrest, tamponade, pulmonary embolism, aortic dissection, and ECMO. As you can see in this chart, the method of choice for most of the parameters is the echocardiography, and there are some limitations with the use of pulmonary artery catheter. The LIDCO, which is lithium dilution cardiac output, continuous cardiac output monitoring, has advantage of it uses the principle of pulse contour analysis. It is a semi-invasive method, and it gives us stroke volume variation. And there is a validation study which finds a good correlation with PS. Pulse contour index continuous cardiac output monitoring uses Stewart-Hamilton principle, which says that if you inject a known amount of solution in blood, the concentration on the left side, which can be measured, and dividing those two terms will give us the cardiac output. So it gives us intrathoracic blood volume, global end diastolic volume, extravascular lung water in critically ill patients as well as high-risk surgical patients. Esophageal Doppler has shown advantages. It measures the velocity time integral or descending thoracic aorta. Although its indications are limited, but it is non-invasive. FlowTrack gives us the measured as well as the derived data And the validation studies say there is good correlation between flow drag and PA catheter in various studies, including off-pump CABGs. Other non-invasive monitors include bioimpedance and bioreactance. Both these techniques use electric current with low ampere and high frequency, and it measures the current at both the ends with the principle that the pulsatile blood flow carries the current, while the tissue and skin they differ the current. So the current applied on the one side and current measured on the opposite side will give us cardiac monitoring, cardiac output monitoring, but only thing is the flow has to be pulsatile. Ecosystem or partial CO2 rebreathing system works on a principle that in the brief period of rebreathing, CO2 elimination and end-tidal CO2 ratio will give us cardiac output. The ultrasonic cardiac output monitor can be applied. It is a non-invasive and portable cardiac output monitor. The probe is applied either left parasternal for pulmonary artery or suprasternal for aorta for measuring PTI, measuring cross-sectional area, which eventually gives us the cardiac output. Photoelectric electric plethysmography is again a non-invasive and continuous monitoring device, which gives us the parameters including heart rate, SpO2, blood pressure, as well as cardiac output. It works on the principle that the pulsatile blood absorbs some light while the tissue does not. So the amount of light applied, absorbed, and detected on the other side, that gives the ratio gives us the cardiac output. There are various guidelines and expert consensus, including associations of American Society of Echocardiography, SCCM, and European Society of Intensive Care Management, which all say that echo should be the first line guide in ICU or PACs for selected cases only, prefer dynamic and less invasive monitoring, and as per these studies, PA catheter is not recommended for routine use. There are some future trends also regarding this artificial intelligence based echo analysis for automatic cardiac output estimation, portable machines, variables cardiac output monitors with emphasis on dynamic and individualized monitoring as per the patient profile, perioperative or critical care. So concluding, the PA catheter offers no survival benefit in most of the patients, and advanced echo and non-invasive tools are safer and effective. Thank you.
Thank you, Vikrant. We'll call for the next speaker, Dr. June. She will talk against the motion, that is, the pulmonary artery catheter should not be completely replaced.
Good afternoon, everyone. I am Dr. June from second year PDT, IPGMA. I'll be talking on the should the pulmonary artery catheter be completely replaced. I said no, PAC is still gold standard for precise pulmonary pressure and cardiac output measurement. In 1969, concept and developed the idea of flow-directed catheter that would be guided through right heart chamber. In 1970, the first clinical use of PA catheter was reported. The device quickly gained popularity because it allowed the bedside measurement of pulmonary capillary wedge pressure, a surrogate of LA pressure. In 1970 to 1980, widespread adoption of PA catheter. In 1990, re-evaluation and controversy. Several observation studies raised concern that PAC use did not improve and might worsen the patient outcome. From 2000 till now, the target use a recent study and guideline have emphasized selective rather than routine use. PAC remains an important tool in specific setting, including complex cardiogenic shock, advanced heart failure, severe pulmonary artery hypertension. Still gold standard for cardiac output monitoring, pulmonary artery pressure, mixed venous oxygen saturation, blood temperature monitoring. Why PAC remains the gold standard? It measures direct intracardiac and pulmonary pressure. Continuous mixed venous oxygen monitoring provides unique insight into oxygen delivery and consumption balance, essential in conditions where indirect or estimated value may mislead management decisions. In example, in patient with sepsis with poor LV function, echo may show hyperdynamic LV, but true SVR is low, filling pressure are high. PAC use give accurate SVR, cardiac index, CVP, and pulmonary artery occlusion pressure. The variable measured with PA catheters are directly measured variable, indirect derived variables. The directly measured variables are RA, RV, PA pressure, pulmonary artery occlusion pressure, cardiac output, mixed venous oxygen saturation, core temperature. And derived variables are stroke volume, SVR, PVR, RV, ejection fraction, oxygen delivery, and extraction. Application of pulmonary artery catheter in high-risk surgical procedure, quantification of left to right shunt, evaluation of cardiac and pulmonary transplant patient, assessment of RV function and failure, fluid responsiveness, capillary pulmonary hypertension, differentiating pre-capillary and post-capillary pulmonary hypertension. JACC 2020, this is retrospective study where patient data was collected retrospectively from 8 tertiary care centers from in 2016 to 2019. It shows in patient with cardiogenic shock enrolled from 8 tertiary centers having complete invasive hemodynamic profile via PA catheter was associated with minimum mortality as compared to non-PAC monitor patient. Annals of Cardiac Anesthesia 2021, the PAC remains a valuable tool in modern clinical practice, particularly in management of critically ill and hemodynamically unstable patients. When used appropriately, and it provides comprehensive information. The key to maximizing the benefit of PAC lies in proper patient selection and operative expertise. These are another studies from critical care cardiological trial. In this trial, total patient included in this trial was 3,000. Out of that, 2,000 patient with cardiogenic shock included in this study. In this study, patient was divided in two groups: PAC with PAC, without PAC. In patient with PAC, the mortality rate was 28.4, and patient with no PAC, the mortality rate was 35%. This is another study. The use of PAC during cardiac surgery is associated with decreased length of hospital stay and reduced cardiopulmonary morbidity. Journal of Cardiothoracic and Vascular Anesthesia. PAC remains controversial yet commonly used tool for hemodynamic monitoring. Selective patient-specific use is currently the most evidence approach. Limitation of advanced echo and minimally invasive monitors. Echocardiography is operator dependent and intermittent. It's not a continuous monitoring. Non-invasive monitor like pulse control, bioreactors rely on assumption that may not hold in critically ill patient. Accuracy drop in arrhythmia, mechanical ventilation, or altered vascular tone state. Limited ability to measure pulmonary artery pressure and mixed venous oxygen saturation, essential parameter for advanced decision making. Argument against the replacing PAC. Echocardiography and minimally invasive monitors complement to each other, no replace PAC. Loss of continuous quantitative hemodynamic data limits the decision precision. Trading and inter-observer variability challenge the reproducibility of echo-based assessment. The clinical outcome depends on integration of multimodal data. PAC provides the anchor reference. The disadvantage of PICO arterial waveform artifact may significantly affect the data accuracy. It does not measure the it is not inability to measure the PAP, pulmonary artery pressure. The disadvantage of LIDCO, inability to measure PAP and arterial waveform artifact may significantly affect the data accuracy. And echocardiography disadvantages are require significant training and expertise. Operator dependent, continuous monitoring not available, and esophageal injury was there with echocardiography.
Question, query from anyone? This moderation to be done with Dr. Shomi Dash for an emergency causes. She is not able to attend this evening. She has sent me the slides that I am reading out. There are some survey studies that proves that pulmonary artery catheter cannot be totally contraindicated for some of the cases. In a study, Anesthesia Analysis 2002, the use of and preferences of transesophageal echocardiogram and the PA catheter among the cardiovascular anesthesiologists, they have concluded that even with the availability of the transesophageal echocardiography, pulmonary artery catheter remained used and preferred by more than twice as respondents as TE. They have a cross-sectional study among the anesthesiologists in Canada and US with the number of responders in 265. PA catheters remain preferred monitored in both cardiac and the vascular surgeries. Now, in another study done in 2011, do we need pulmonary artery catheter in cardiac anesthesia? It's an Indian perspective. They have concluded that use of PA catheters cannot be recommended as a routine, but a definite role in selected patients undergoing cardiac surgeries, like the CABG with poor LV function, LV aneurysmectomy, patient with recent MI, pulmonary hypertension, diastolic dysfunction, acute ventricular septal rupture, insertion of LVAD. These are the absolute indications of doing inserting PA catheter that for all these kind of patients. So this is the exam question, that what are the absolute indications of PA catheter? These are the 5 absolute indications. Now, in another study done in 2015, the current use of PA catheter in cardiac surgery, a survey study, they have concluded that majority of the responders still prefer to use PA catheter for most of the cardiac surgeries. Transesophageal echocardiography remains most popular supplemental or alternative hemodynamic monitoring tool. Now, why PAC and TE are complementary, not competitive? As all data furthering the pressures, resistance, and flows are more reliably determined by PA catheters. And the TE remains the surrogate of pulmonary capillary wedge pressure, the TE minus EA, or the time interval between the onset of early diastolic mitral flow velocity and the annular early diastolic velocity. It requires expertise training, and it is difficult to apply in intraoperative settings with the manipulation of the heart by the surgeons. So the general consensus regarding the measurements of cardiac output by TE is strongly operator dependent and less reliable than the thermodilation technique. So TE provides a good profile of systolic function like LV size, ejection fraction, FAC, which are not possible by PA catheters. Okay, and the diastolic dysfunction can be diagnosed and treated only by TE. Fluid responsiveness is better defined by TE derived variables. And some of information can be derived from the PA catheters as well. That is the pulmonary capillary wedge pressure, peak pulmonary pressure variations. So unlike T, PA catheter allows measurements of MVO2 and oxygen delivery and the consumption variables. So limitations of TE are that it is a semi-quantitative method and does not permit continuous monitoring. So PA catheter and TE both are complementary, not competitive. So we need both. In another study done in 2002, Canadian Journal of Anesthesia, the appropriateness of pulmonary catheter in cardiac surgeries, they have concluded that they have a strong agreement that the PA catheter is appropriate in some of the patient scenarios and the agreements that it is appropriate for the others. So some of the patients where the PA catheter is appropriate as has to be done, but not all the cases. Studies show no benefit of PA catheter over CVP catheter in low risk patients with a preserved ventricular functions undergoing the off-pump CABGs. The study has been done in 2006 with the JCPA, published in JCPA journals and Indian Journal of Clinical Anesthesia 2025. So why does the PA catheter still remains useful in clinical practices? The PA catheters are the only tool that provides the continuous monitoring of the PA pressure, the right-sided and the left-sided filling pressure, the cardiac output and the mixed venous oxygen saturation. That are very important parameters we need to know in our day-to-day practice. The risks are mainly due to insertion of the central catheters, not the pulmonary artery catheters. And the additional cost, that is some says the cost of PA catheters, but it is minimal relative to the cost of the intensive care. So to conclude, the use of PA catheter cannot be recommended for all patients. It should not be used as a routine practice, but it has a definite role of selected group of patients undergoing cardiac surgeries and those with present and possible hemodynamic instability, as in conditions like LV systolic and diastolic dysfunction, low cardiac output states, need LV reshaping, RV dysfunction, pulmonary hypertension, need of mechanical circulatory support, and mechanical complications of the AMI. So, in order to translate PA catheters derived data into tangible outcome benefits, PA catheters have to be used within the context of a defined treatment protocol. So, thank you very much for the patient hearing. Any questions in this regard? There is no query. We will move to our next session, that is the goal-directed fluid therapy using dynamic parameters should replace the CVP-guided therapy in all cardiac surgeries. To moderate this session, I would like to ask the Secretary of ISA West Bengal, Dr. Debashish Ghosh.
Brother, I am a junior of Monalisa Lee. This is more apt. So, how many of you think that for all cardiac surgery, CVP is adequate and no extra goal-related hemodynamic monitor is needed? None. Okay. For off-pump CABG? For off-pump CABG, only CVP, no other goal-related hemodynamic monitor is needed. Erpore how many of us? None. But practice করতে কিন্তু খুব সমস্যা হয়। যাই হোক, ঠিক আছে। Okay. So with this notion, so for the pro, third option টা পরে আসবে। For the pro, Shautik Chakraborty, Shautik is from RTX, Kolkata. Okay. What is your Shautik?
So the computers.
So this is one problem. The more complex thermodynamics monitor is difficult to use. And if you are not used to it, then again it's more difficult. So what is happening is in the probe for a modern, more complex thermodynamic monitor, and look, this is not opening at all. No, not for you. ওর একটু লাইন করতে সময় লাগছে লাইনটা হয়ে গেলেই ও মনিটরিংটা জিরোইং করে স্টার্ট করবে সো বি পেশেন্ট
Good evening to all. Good evening to all the teachers, all my seniors, my colleagues. I am Dr. Shokti Chakraborty, first year DNB trained from Arantel Hospital. And my topic is whether goal-directed fluid therapy is a more accurate predictor of fluid responsiveness in cardiac surgery, using dynamic parameters in cardiac. So it's goal-directed fluid therapy. So in cardiac surgery, what is our goal? The goal is to optimize the cardiac output by giving the right amount of fluid at the right time, but without causing fluid overload, and also maintaining adequate tissue perfusion. So it is an individualized hemodynamically guided approach to optimize the patient's preload, stroke volume, and cardiac output while avoiding both fluid overload and hypovolemia. Rather than giving fixed amounts, the clinician, we should titrate fluid based on real-time physiological parameters. Dynamic indices, they are more predominant to modern day goal-directed fluid therapy because they predict fluid responsiveness. Like what we get from the Frank study, that when a certain amount of fluid is given or when the ventricle is filled, what is the amount of rise of cardiac output in response to that volume. As we know the static and the dynamic parameters. So the commonly used dynamic parameters are pulse pressure variation, stroke volume variation, even passive leg raise test. So why should we prefer dynamic indices? Static parameters like central venous pressure or pulmonary occlusion pressure, they correlate poorly with fluid responsiveness because this fluid responsiveness is a measure of flow but not pressure. These dynamic indices assess the heart-lung interaction during positive pressure ventilation, giving a functional picture of preload dependence. And they are more predictive, not just descriptive. The key indices of goal-directed fluid therapy, the dynamic parameters like stroke volume variation, where there is variation in stroke volume during the respiratory cycle, and we consider it's fluid responsive when the stroke volume variation is more than 10 to 13% in certain control conditions like controlled mechanical ventilation, sinus rhythm, and tidal volume of at least 6 to 8 ml per kg. Similarly, for pulse pressure variation and passive leg raise test. So generally, this is the common algorithm which we follow. The stroke volume variation, when it's more than 13%, we generally say that it's fluid responsive, but less than 13%, we see for the mean arterial pressure. If it's less than 65 millimeter of mercury, then instead of fluid, we should go early for the vasopressor administration. This is the current algorithm followed for goal-directed fluid therapy in operating room, but all the recent studies, this algorithm was mainly done for all non-cardiac cases, for abdominal surgeries and all. No specific algorithm has still been devised for cardiac surgery. This is the most commonly used parameter, pulse pressure variation, which is proportional to stroke volume. This is the specific formula, pulse pressure variation max by minimum divided by the mean pulse pressure. Specifically, what I told earlier, the percentage of more than 10 to 13% is generally indicated of fluid responsive. Then why should not we use static parameters like central venous pressure? It has some limitation, like central venous pressure is a measure of pressure, whereas fluid responsiveness is a measure of flow. So it doesn't predict fluid responsiveness. Multiple studies and meta-analysis have shown almost no correlation between CVP values and actual ability of the heart to increase the stroke volume. CVP is heavily influenced by mechanical ventilation, intrathoracic pressure, RV dysfunction, catheter position, and compliance of the venous system. Even CVP can lead to fluid overload, like using CVP threshold encourages excessive fluid administration, which is dangerous in cardiac surgery. The advantages of dynamic parameters are it reduces the reduced post-operative, it has shown reduced post-operative complications, reduced length of stay, lower risk of fluid overload, improved tissue perfusion, and better hemodynamic stability. Then what is our main purpose in goal-directed fluid therapy in cardiac surgery? The main purpose is to optimize preload, contractility, and afterload using dynamic patient-specific hemodynamic target rather than fixed volumes. And in cardiac surgery, this helps in reduction of low cardiac output syndrome, acute kidney injury, prolonged ventilatory support, and reduced length of stay in hospital. So, why should we use goal-directed fluid therapy in cardiac surgery? Cardiac surgery, all the cardiac surgery cases, specifically on CPBs, so cardiopulmonary bypass, they show us inherent hemodynamic perturbations like fluid shift, change in vascular tone, capillary leak, myocardial style. Suboptimal fluid management can contribute to complications like myocardial output, pulmonary edema, renal dysfunction, and ultimately lead to prolonged ICU stay. So this goal-directed therapy is hypothesized to mitigate this risk by better matching the fluid delivery to patients' functional hemodynamic trigger. The commonly used monitors which you use for goal-directed fluid therapy, the advanced monitor like T, pulse control or flow track, esophageal Doppler. These are some of the principles which are found with the recent literature, like which are followed in cardiac surgery. Then give fluids only if it is fluid responsive. Like look for the dynamic preload indices. Second is the use of restrictive balanced fluids. And third is the prefer vasoactive drugs over fluids, like what was mentioned in the previous algorithm, that if in spite of giving fluid bolus, if the stroke volume is not increasing, that instead of giving more fluids, better to shift to early vasopressors. This is what was recently found in the literature regarding goal-directed therapy for cardiac surgery. Early use of fluids and better to shift to inotropes or vasopressors so that the complications reduce. This is the algorithm for this stroke volume variation using goal-directed fluid therapy. And this was the last study, this was the most recent study on goal-directed fluid therapy by Davinder Ramsingh et al., where it was found that cardiac surgery patients are at increased risk of post-operative complication and prolonged length of stay. He initiated a quality improvement project focusing on the implementation of a goal-directed protocol, which was applied from the immediate post-bypass period into the intensive care. And the hypothesis was that this protocol would decrease the ICU length of stay and possibly improve the post-operative outcome. And he found that the hospital length of stay, although didn't demonstrate a significant reduction, but there was a significant reduction in total administered volume of inotropic medication reduced incidence of acute kidney injury, and also there was reduced length of ICU stay. And now, goal-directed fluid therapy has now been included in the ERAS protocol, enhanced recovery after cardiac surgery principle, which focuses on maintaining euvolemia, optimizing stroke volume and oxygen delivery, reducing post-operative complication, supporting early mobilization and extubation, and aligns with these goals by using this in real-time data. These are some of the literatures showing supporting the goal-directed fluid therapy in cardiac surgery. In 2013, IIR Seconi, Hamilton, and Rhodes, where they showed a systemic review and meta-analysis, where they did a 5 total using they took total nearly 699 patients, and their finding was goal-directed therapy reduced post-operative complication rate and reduced hospital stay. Similarly, for Osawa et al., they showed ICU length of stay and hospital stay were shorter in goal-directed fluid therapy group, and dobutamine use was less. Same systemic review by A. Dushyanthan et al. In 2020 looked at many surgical patients, including cardiothoracic surgery. They found that goal-directed fluid therapy was associated with a reduction in post-operative pulmonary complications, particularly when using a combination of fluid vasoactive drugs rather than only using fluids. And these are some of the other randomized controlled trials. So, what are the benefits reported from this literature? That goal-directed fluid therapy in cardiac surgery are associated with reduced post-operative complications, shorter length of hospital stay, reduced infection, lower incidence of low cardiac output syndrome, and potential resource utilization benefit. But there is more still now, as there are many studies and literature on goal-directed fluid therapy in non-cardiac surgery. But it's a developing thing in the last 5 years. Few studies have emerged where they have recommended as level 2A recommendation for goal-directed fluid therapy in cardiac surgeries. Right.
Okay. So, excellent talk by you. And we will take the challenges later on after the delivery of the speech. Can anyone tell what is the similarity between Gautam Buddha and Rashikant? Yeah.
Both are
Rahul. So we have the Rahul Bakshi here. And Adantekuru and VM Billa, they have a very unique connection. Very old people can tell about it. They have some stories about it, about a person. So we first have Rahul among us, and then we will be on the debate. Okay, Rahul.
Good afternoon, everyone. My name is Dr. Rahul Bakshi. Today I am going to speak in summation about the topic that goal-directed fluid therapy in dynamic parameters should replace CVP guided therapy in all cardiac surgeries. So, starting with GTFT, that is goal directed fluid therapy, proposes dynamic pieces for guiding fluids. However, blanket replacement is unsafe in cardiac surgery. Now, CVP, it measures the RV filling pressure. It gives an estimation of the intravascular volume status. It is used for the assessment of the RV function. It reflects the RA pressure, the venous return, the RV preload, and the intrathoracic dynamics. It is used for trending and waveform assessment. Now, what is the role of CVP in cardiac surgery? Firstly, it is used during induction, immediate post-induction period for detecting a sudden drop in venous return that is associated with vasodilation and RV failure. It is also used for guiding cautious fluid administration in preload dependent states. And it is used for monitoring trends rather than the absolute value. That is, the real value of CVP lies in its trend and not the single digit number. It's used during CPB. It is used for detection of malposition or obstruction of the venous cannula, for identifying venous air entrainment, and to monitor persistent right heart distension. Now, this is the CVP waveform diagram. I'm not going to details of the waveforms. Now, what are the dynamic indices? The dynamic indices are used for predicting fluid responsiveness under specific conditions. That is, they work under specific, they have a particular core principle under which they work. They do not work outside their core principle mechanisms. It is used for measuring the cyclic preload changes. Now, what are the must-haves during using of the dynamic indices? Is the patient should be under mechanical ventilation. There should be a sinus rhythm. It should be a closed chest condition. The tidal volume should be preferably more than 8 ml per kg body weight, and the lung compliance should be normal. Now, how does it work? The dynamic indices. That is, when the patient is being mechanically ventilated, there is a positive pressure ventilation. During inspiration, the right heart will have a reduced venous return, so the stroke volume will reduce on the right side of the heart. And during the same cardiac cycle, the left heart will have a increased stroke volume, and in the next cardiac cycles, it will have a reduced stroke volume. So, why does the assumption fail? That is, the dynamic indices fail in the cardiac surgeries, because the cardiac surgeries often violate the core assumptions which are used in the dynamic indices. Now, the dynamic indices work with the Franz-Starling concept of the fluid responsiveness. If you see the Franz-Starling curve, there are two parts. That is the steep part of the curve where the patients are fluid responsive, the flat part where the patients are not fluid responsive. Now, in a patient with RV dysfunction, the curve which we see in this, the second one, the curve is flattened. So, the fluid responsiveness in the RV dysfunction patients is very less. So, what does the RV dysfunction have an impact on the dynamic indices? It uncouples the preload stroke volume response. So, the pulse pressure variation or the stroke volume variation becomes unreliable despite high values. Now, the patient with RV dysfunction will have a reduced RV contraction. The CVP will be high, but the positive predictive value of the PPV and the SPV will be remarkably low. Now, this is a table which I am showing, which will show which is showing the limitations of each and every dynamic indices, starting with the pulse pressure variation and the stroke volume variations. That is, in the spontaneous breathing activity patients, it will have its limitations in low tidal volume ventilation, and in lungs with low compliance, and in patients with cardiac arrhythmias. Along with that, the other parameters, that is the respiratory variations of IVC diameter, respiratory variations of SVC diameter, of the IJV diameter, and the end expiratory occlusion test, and the passive leg raising test, and the mini fluid challenge test. Now, this is the Penny study, which is a fluid challenge study. In this, there was an international audit of the fluid challenge practices, where the static preload markers were used in 35.5% of the cases,
Within the static marker group, CVP was the most predominant variable around, and it accounted for 25.8% of all the fluid challenges. In the Penny study, 73% of all the parameters were CVP, whereas pulse pressure variation or the stroke volume variations were less than 10%. In the next journal, which was done by Eric T. Wall et al., they showed that in patients with open chest conditions, the p-value of pulse pressure variation was 0.04 and that of the stroke volume variation was 0.03. Because in open chest conditions, the core principle of the dynamic indices changed totally. Because in open chest conditions, the positive intrathoracic pressure is not propagated as good as in the closed chest conditions. Now, the next journal, which is showing that in patients with atrial fibrillations or in patients with any other cardiac arrhythmias, the dynamic indices of fluid assessment fail to give complete data as compared to patients with normal sinus rhythm. Now, the next journal going by Daniel et al., which showed that pulse pressure variations fail to predict fluid responsiveness in patients who are given low tidal volume as compared with patients who received more than 8 ml per kg tidal volume. The next journal by Didier et al. Showed that the pulse pressure variation and stroke volume variation during increased intra-abdominal pressure, they showed that the responsiveness of PPV and SVV for fluid responsiveness deteriorated under elevated intra-abdominal pressure. Now, why can't CVP be replaced? Because it detects the congestion risk and the pulse pressure variation, the stroke volume variations do not. It works in patients with cardiac arrhythmias and in open chest conditions. Summary, CVP is reliable across surgical phases, whereas dynamic indices only work under strict criteria. So, integration and not replacement is the key. CVP still remains essential for safe decisions.
Thank you, Rahul. So, Sotik should have a chance counter this. Sotik, please.
As I said, goal-directed fluid. As I said, the goal-directed fluid therapy still goes better, although the CVP works better in case of like open chest and but still goal-directed fluid therapy helps better because it predicts more of this fluid. What goal we are all trying to achieve, this fluid responsiveness of this increase in this cardiac output. So it works better with goal-directed fluid therapy using these dynamic parameters. Because CVP doesn't come, it's not a low parameter, it's more of a pressure.
So as I just said that CVP, it is not just about the number, it is rather based on the waveform and certain conditions that I have previously mentioned, like low tidal volume patients, low tidal volume ventilation, patients with less lung compliance, or in open chest conditions, or in cardiac arrhythmia. The dynamic parameters are not useful, and in that case, we only have CVP.
Okay. So one particular word, that is all. That is the Sarupachar. If it is needed for all, if all this word was not there, then the debate would have been another spectrum. And one point Rahul has very aptly mentioned, that is about the risk of congestion. Now, if a patient has a slightly low cardiac output, but a very high congestion risk, that is more detrimental as far as the organ perfusion and the organ dysfunction is concerned. Particularly some surgeries like the liver surgery, it's the hepatectomy. Surgeon always tells that they have to look for the CVP. So that is the point. Like liver transplant is one of the few surgeries where being a non-cardiac surgery, T is a must. So this is a game. So obviously in scientific research with a limited parameter or strict limited parameter like no spontaneous breathing. Another thing is that even if the patient is on ventilator and if it is a very low tidal volume ventilation, like 4 to 6 like that, and I know some persons when they put their patients on ECMO, they keep them on a very low tidal volume like these things. And if it is a 4 ml per kg body weight, ideal body weight, then again these goal-directed fluid therapy is at loss. But many times CVP gives us very false assumptions. Just simple upon CVP, you are getting a very high CVP, and thereafter, if you tell the surgeon where the tip is, they will tell that the tip is here and tip is here. So there are many pros and cons. So all are not correct. कभी किसी को मुकम्मल जहां नहीं मिलता, कभी जमी तो कभी आसमान नहीं मिलता. So CVP has its own some charms and advantages, and definitely the goal-directed monitors has its own charms. So किसी ने नहीं हारा, सबने जीता है. But one thing to please remember that if you want to go for a private case of CVP under Shastro Shati or like this, and you are telling the team that you are one day very good monitor, at least a BA gap, then to problem हो जाएगा इस case से. Okay, I think you have enjoyed the show. Thank you, and claps for them.
Any question for Dr. Bora? Audience, any question?
Just when it is amongst the students, I know that we practice as consultants, but when we are talking to students in the forum, I think that finance, and especially when they are talking about the finance and that thing, that should not be the consideration. What happens nowadays, they are very smart. So these things, ম্যাডাম পালমোনারি আর্টারি ক্যাথেটার দেবেন অর্পণ দ্বারা সারা জীবন দিয়ে গেল, আমাকে জিজ্ঞাসা করে পালমোনারি আর্টারি ক্যাথেটারটা দেবেন ম্যাডাম, দরকার আছে? আগে শিখবো কি করে দিতে হয়, কি করে তারপরে নয় আমার বয়সে বাদ দিও. So what I think, when it is between the finance and the Shastro Shati scheme should not go, probably they're smarter than me, আমার থেকে বেশি ভালো finance বসে, but I think that should not be given considerations, particularly in this kind of academic forum. But এটাই আছে আমার বলার ছিল. I understand that তুই
এটার answer আমি দেব. এটা হচ্ছে I always because I always abide by my seniors, এবং আমার যারা সিনিয়র কেউ কোনোদিন বলতে পারবে না যে আমি কখনো তাদের কোনো বলা অন্য করেছি, particularly diabetes তো একদমই না. তো
Or you second me or you second Devashish? Or I didn't get it.
One thing. I was a PGT of Bardhaman Medical College, and Dailokidi was my senior, and Dailokidi passed for a gala, and our HOD was Professor Sarvapalli. He told me one thing, যে দেখো ভাই, ছোট থেকে আমাদের বাবা মারা বলেছে পয়সা খারাপ জিনিস, এটা সব থেকে খারাপ কথা দিয়েছে. পয়সা হচ্ছে সব থেকে বড় জিনিস যেটাকে তুমি খারাপ ভাববে না, এবং তারপরে তুমি তার চিকিৎসা করতে পারবে. কোনো একটা পেশেন্ট যার হয়তো আইসিডি বসানোটা হচ্ছে একদম ইম্পর্টেন্ট, থ্যাংক ইউ অলরেডি লেখা আছে, তো এবারে তাকে আইসিডি বসানো হলো, সে তার জমি টমি সবকিছু বেঁচে আইসিডি এগুলো, পার্টিকুলারলি হার্ট ট্রান্সপ্লান্টের ক্ষেত্রে প্লাবন স্যার আমাকে যেটা বলেছিলেন, হি ওয়েন্ট ফর দ্য পেশেন্টস রুম, দেয়ার ফ্যামিলি, দেয়ার অ্যাটমসফিয়ার নিজে দেখতে গেছিলেন, যে সে সেখানে বাড়ি ফিরে কোথায় থাকবে, তার কিরকম পয়সা কড়ি আছে, এবং তাকে পোস্টারে কিরকম ভাবে রাখা হবে না রাখা হবে ইত্যাদি বিষয়. সুতরাং finance is not at all a bad thing. Without finance, what Didi has told, the scientific basis. এই যে CBP দিয়ে অপফর্ম CABG করা যায়, এই যে স্পাইনালে ল্যাপগুলি করা যায়, এটা যতদিন না কেউ করতে গেছে ততদিন পর্যন্ত তারা সেটাকে রিলিজ করেছে। There was a time স্পাইনালে সিজারিয়ান সেকশন করা যেত না। Then the reports came after a lot of person has given spinal in cesarean section. No, it's safe. Then it came that it is the standard of choice. So if you see just now in this moment, এই কলকাতার গোটা ওয়েস্ট বেঙ্গলে যে কটা অপফর্ম সার্জারি হচ্ছে CABG, take it from me that most of the cases are being done only on CBP. That doesn't justify the scientific point.
কথা বলছি সিএবিতে করছে সার্জন বললো তাহলে স্বাস্থ্যসাথী কেস আমি লিমাটা দেবো না, ঠিক আছে? নাও what is going to happen?
Yeah, and in some cases,
Why are you doing CABG? It is only just to give a lima to LAD, that is giving outperforming your state. একটাই তো আছে নাকি?
one of the standard
vein to PD or vein to OM is not outperforming the states. It is a lima to LAD. Clipper খরচাটা বাঁচানোর জন্য আমি লিমাটা দেবো।
What do you think?
So we are actually, আমি তোকে বলছি, it is the other way around. If you have a স্বাস্থ্যসাথী কেস, নির্ভয়ে PA ক্যাথেটারটি ইউজ করা যাবে। তার কারণ হচ্ছে the patient is not paying from his pocket. You need not to speak to the patient relative,
but for your pocket.
No, not from my pocket, not from my pocket. It is well accommodated. It is well accommodated. ঠিক আছে? একটা পেশেন্ট যদি ক্র্যাশ করে তারপরে তুই কি করবি, the ultimate outcome. Don't even think the স্বাস্থ্যসাথী কেস is going to আজকাল এমনি ঢুকে যাচ্ছে, ঠিক আছে? You have to pay 10,000 rupees who is referring to you. All kind of things. তুই যত নিজেকে ছোট করবি এবার তুই বলবি তাহলে আমার সেন্ট্রাল লাইনে দরকার নেই।
সেন্ট্রাল লাইনে যদি দরকার না থাকে, finance doesn't justify the requirement of প্লাবন স্যার দেখবেন, কাকলি ম্যাডাম দেখবেন, অর্পণদা দেখবে, বাট মোনালিসা আমরা সবাই জানি স্টুডেন্টসরা দেখবে না।
Not the finance one. You are talking that only finance, then it's something different.
Like we have different opinions.
Different opinions can be there. Just like that, the PA catheter, usage of PA catheter, till now, got a D indication for opfom CABG. And there are lots of debate.
একটা রিসেন্ট এমআই যদি স্বাস্থ্যসাথী কেস সিবিজি করবি তার PA ক্যাথেটারটা না দিস,
ফিনান্সের কথা বললে হবে না। ফিনান্সের কথা বলছি।
তার মেন্টাল পিসের মতো একটা ব্যাপার আছে। তার মধ্যে যে আমি পেরিফেরাল লাইন দিয়েছি, পুরো সমস্যা নেই। তোকে 5 ml নড়ায় পেরিফেরাল লাইন দিতে পারে না। লোকে অনেকে সিইউপি লাগাচ্ছে কিন্তু ইয়ে করছে, মনিটর করছে না, শুধু তো 8 লাইন লাগিয়ে পড়ছে। তো সিইউপিটা দরকার কি? আমি দুটো 16 দিয়ে দেন।
You know what is available
Yeah.
and what is right to do.
In the academic context, what Rajdoki very rightly said, and maybe Ormodla is also saying that is we should know what is to be done, what are the options available. Now coming to in the practicing field, that you will decide later when you go to the practicing field. But you should know what are your right options, what I should do. Because if I don't know what I should do, I'll never be doing, and that is wrong. I may not be using a tea, but I should know that here are the uses, and if I get one, I should be using it. Because otherwise, when you're given one, you will just go without it. That is the difference.
That's it.
So time has come up. Just one last 10-second point. So when I was in PGT and I had one medical officer with us. So one day after spinal anesthesia, lot of hypotension, I am giving turning, giving faint press, everything. And he came and said, "ঠিক আছে, ছড়ে যাও, আমি করে দিচ্ছি, ম্যানেজ করে দিচ্ছি।" ঠিক আছে। তো কিছুক্ষণ পরে I went, what management was there, and somehow I couldn't find the NIPP cuff. Where is the NIPP cuff? বলছে বড্ড টেনশন হচ্ছিল, আমি খুলে রেখে দিয়েছি, and I am managing like this. So it is not like that also, but the scientific data, and you will, when you will go in the further depth, the scientific data many times is actually driven by the finance of the big financial houses. It is coming. So I'm not against this thing. So whatever we are used, that we have to use on the scientific basis. এবং সহজ কথা যায় না বলা সহজে. The simple truth is not always very easy to speak about. Thank you, Monisha.
Thank you, Devashish. It's an excellent discussion with all the academics and the practical associations also. And I think the students should know both of the things, the academics and the practical aspects also, because they are the persons, they are the future of cardiac anesthesia. They are, after a few years, they will be our colleagues as practicing doctors. So they should know what is right and what to be done. Every single aspect, all the pros and cons of every single practices we are having. That is why the debate is there. The today's session is because of that is also. Okay, without wasting time, I am moving to our next session. That is, an anesthesiologist should lead the cardiac ICU and the ECMO teams. A very controversial debate. I would like to call Dr. Kakuli Ghosh, Professor, IPGMER, Department of Cardiac Anesthesia, is my seniors and my very dear senior ma'am. Kakuli, please come and have your stage.
Thank you, Mona Lisa. Thank you, everybody present over here. Today, the topic is topic for this next debate. Two of my students and my present colleague, junior colleague, is going to speak for and against the notion that is anesthesiologists should be leading the cardiac ICU and the ECMO ICU or the ECMO team. So, for this notion, the speaker is Dr. Saurav Das. Saurav, please come and deliver your points in favor of this statement. And next is Dr. Rushna Sharma, who is our first year DOPDT in IPGMER, and Saurav is now our junior resident and my colleague in the Department of Cardiac Anesthesia in IPGMER.
Good afternoon, everyone. Today I want to start this session with this statement that leadership should align with skill set, not tradition. Cardiac ICU and ECMO management demand real-time physiologic understanding. Anesthesiologists are uniquely positioned due to this perioperative expertise, unique integration of physiology and pharmacological knowledge, advanced ventilator management expertise, and not only that, the TE proficiency is most important and the most, I think, it is the most important tool nowadays to manage cardiac ICU and perioperative cardiac patients. So now, perioperative continuity of care is very important thing to understand, because anesthesiologists are the only people who manages the patient from induction to CPB, then the separation till the transfer to ICU. They understand the intraoperative complications, intraoperative nuances, and the physiologies very well. This continuity ensures the early, safer postoperative care. They are also well equipped with the knowledge of the physiology. So they have deep expertise in hemodynamics, preload and afterload manipulations, and the myocardial performances. They are also expert in the titration of the vasoactive agents, mechanical support, and acute circulatory failure. These are vitals for the CICU decision making in terms of cardiogenic shock, hemodynamic management, and cardiac output optimization. They are also experts in ventilation and gas exchange. They optimize heart-lung interactions immediately post-bypass. Most cardiac ICU patients requires advanced ventilatory modes. Thus, skillful adjustment for these things helpful in the weaning protocol and early extubation as per ERAX protocol. ERAX means early recovery from cardiac surgery that mostly involved in the fast tracking of cardiac surgery. That I will come later on. Anesthesiologists, now we can say that anesthesiologists already leading the intraoperative crisis management. That is because of their familiarity with cardiac arrest algorithm, post CPB, vasoplegia, and arrhythmias. Quick decision making, because we are always on our tiptoe to manage these all intricacies and the hemodynamic nuances. So quick decision making under pressure translates seamlessly to the CICO leadership. They are also used to team coordination in emergencies because perfusionist teams are there. We have to also tell the surgeon about what hemodynamic parameter or any problem with perfusion. I can also have to coordinate with the surgeon. We are all doing already that in our day-to-day perioperative ICU scenario. Not only that, the ECMO physiology requires the core skill of cardiac anesthesiologists because ECMO needs integrated knowledge of heart, lung physiology and perfusion and hemodynamics. Anesthesiologists now routinely manages CPB, ventricular assist device, ILP, RVAD, LVAD support. So they are the ideal specialists for ECMO initiation, titration and weaning. They are not only that, they are also expert in the percutaneous cannulation and vascular access. Probably more, I think, in my opinion, more than cardiologists as well. Skilled in ultrasound and TE because TE is central to the ECMO evaluation that maybe VA or VV in LV venting or LV distension when there is there. Anesthesiologist possesses certified extensive TE experiences. Because of that, we can diagnose cardiac tamponade much early than our other counterparts that may be intensivist or cardiac surgeon or cardiologist, interventional cardiologist. They can also diagnose the dysfunction and failure within seconds with the help of TE. Because in our day-to-day practice, we are really dealing with that daily. Being an anesthesiologist, I need not to say sedation and anesthesia neurovascular management. These CICU patients are also required, and we as anesthesiologists can also give our expertise in that area as well, because we are also the sedation specialist. And how to titrate sedation, titration of the sedation is very important because in fast tracking of cardiac anesthesia, that is, we have to use low volatile agents, we have to use, then we have to low opioid, that we are shifted from the era of high narcotic to now in the low narcotic dependent era, so that we can early recovery from anesthesia we can do now. Post-cardiotomy physiology is also, I think, the terrain of anesthesia because hypotension, vasoplegia, low cardiac LCO, low cardiac syndrome, early dysfunction, we can also always see this when we are coming off pump daily. Anesthesiologists manage this intraoperatively every day. And I think we are the most experienced in vasoactive titration and hemodynamic recovery. For these things, patient safety is very much advantageous because of immediate recognition of instability, better prevention of peri-extubation complication, and like I said, stronger crisis management skill improves the survival. Rather than being experience driven, we cardiac anesthesiologists we have the strength protocol driven here. So we excel in ERAS, fast track extubation, transfusion protocol. ECMO weaning protocols often designed by cardiac anesthesiologists. Thus, we have proven leadership in multidisciplinary teams. We used to coordinate surgeon, perfusionist, nurses, technician. OT leadership translates naturally to the ICU environment. And this ensures clear communication and rapid decision cycle that eventually the patient outcome gets better for this. And there is also the global trend is also supporting this anesthesiology leadership. Many top centers like Mayo Cleveland Clinic, Toronto General, they have anesthesia-led CIC. ECMO teams internationally are anesthesia and perfusion driven. evidence shows improved outcomes with anesthesiology leaders. Here I did not add much, but the Massachusetts General Hospital model I want to talk about. This demonstrate the anesthesiologist leadership, where anesthesiology intensivist led shock response team is there. Mobile shock page system for rapid responses are there. PMT medicine approach improves the overall outcome. So in conclusion, I want to tell that anesthesiology has the most holistic skill set for leading the CICU and ECMO team. Mastery of heart, due to mastery of heart-lung physiology, TE and hemodynamic expertise, crisis leadership, sedation and ventilator proficiency, and perioperative continuity. Last but not the least, I want to say we, cardiac anesthesiologists, believe not in exclusive leadership but in multidisciplinary collaboration. Here I want to close my statement with referring to the Achalayathon from the Achalayathon drama of the Rabindranath Tagore. And here I think we are like Panchok, where we can break the traditional system where people always say the cardiologist, no, not the people from anesthesiology with not clear ties, but from cardiology, they say no. We have to change this tradition now. And I had the great opportunity to see Orpon sir, Dipanjan sir in our arena. They are always keep pushing us and keep pushing the limits what we can do as cardiac anesthesiologists. Thank you.
Thank you, Saurav. Saurav has correctly explained that why the cardiac anesthesiologist should be, not the anesthesiologist, but the cardiac anesthesiologist should be leading the cardiac ICU again. And I think this topic is really biased, skewed to one side, because all of us belong to the same super specialty, that is cardiac anesthesia, and we definitely should support this pro. Okay. So I think Rushna will do a difficult job in spite of being a cardiac anesthetist. Would be cardiac anesthetist, and she is going to describe and tell why it should not be. It will be a little difficult for you, though I know in her mind, maybe she is also pro to this solution. Okay, please Rushna, up to the stage.
But she is representing 99% of the public.
Yes, we don't want. That will come at the end.
Hey everyone, for this evening is anesthesiologist should lead the cardiac ICU and ECMO teams, and I'm going to speak against the motion in spite of being an anesthesiologist. So if we go by history, the first ECMO was first used in 1971 in a trauma patient with ARDS, but unfortunately the patient did not survive. The first adult survivor of ECMO was reported by Dr. J. Donald Hill, and it was in 1972. Dr. J. Donald Hill was a very renowned cardiovascular and thoracic surgeon, and he had taken the call for ECMO in this patient. ECMO was used for the first time in a neonate with meconium aspiration syndrome at birth. And she was put on ECMO for 3 days, and she had survived. And this thing was reported by Dr. Bartlett. The question that arises from this slide is that ECMO is not just limited to cardiac situations alone. ECMO is used in a plethora of other situations, and are regular anesthesiologists qualified enough to deal with such neonates or to deal with such polytrauma patients on a day-to-day basis. This is a picture of the infant who had survived. The first neonate was put on ECMO and who had survived. She was named as Baby Esperanza. The person standing on the right is Dr. Bartlett. Dr. Bartlett was again a renowned cardiovascular and thoracic surgeon, and he was also the Chief of General Surgery Program, the Director of Surgical Critical Care Fellowship, and the Director of Extracorporeal Life Support. And he had brought about all these ESLO guidelines. So a person who is so experienced had also felt the need for a dedicated critical care fellowship that was directed only to cardiac patients, only to cardiac situations. So even a person with such expertise felt that his expertise was not enough to deal with such patients, to deal with cardiac critical care ICUs. And that is a point to be taken note of. If we look at the big hospitals and the big centers, we can see that the decision to put patients on ECMO at Mayo Clinic is made by a multidisciplinary team of healthcare providers. This multidisciplinary team, in addition to consisting of cardiac anesthesiologists, also includes cardiologists, cardiovascular surgeons, respiratory care physiologists, social workers, pulmonologists, and many other disciplines. Nutrition is included. If we look at what Johns Hopkins does, Johns Hopkins also does the same thing. The decision to put patient on ECMO is made by a multidisciplinary team of specialists. The decision to put a patient off ECMO is also made by a multidisciplinary team of specialists. This has multiple benefits, one of which is also from a medico-legal point of view. Liability sharing is there when there is a multidisciplinary team. If we look at what the studies say that there is a study assessing the clinical impact of cardiac intensivists in cardiac intensive care units, and it is from the Rescue Registry. And it showed that cardiac intensivists in ICUs, in cardiac ICUs and in ECMO settings, where the decisions were taken by cardiac intensivists, they had better survival, they had reduced in-hospital all-cause and cardiac mortality rates as well as deaths. Similarly, other studies have also shown that CCUs led by cardiac intensive care specialists had lower in all-cause mortalities. Now, what was a cardiac intensivist? A cardiac intensivist was defined as a physician who had completed at least a 2-year cardiology fellowship, and they were specialized in treating patients with coronary syndromes in the critical care cardiac ICU settings. Since the topic is anesthesiologists should lead the cardiac ICU teams, I don't think the normal anesthesia training, the 3 years anesthesia MD or DNP training, incorporates a 2-year cardiology fellowship. Neither do we have much experience to cardiac ICU settings or to cardiac surgery settings in general. So, in conclusion, perhaps there is definitely scope for cardiac anesthesiologists to lead ECMO teams and to lead cardiac ICU teams, but perhaps now is not. Perhaps we are not yet ready. We would need better training. We would need more training on nutrition, physiotherapy, other comorbid conditions such as kidney renal replacement therapies, and other training on acute cardiovascular emergencies and emergency cardiovascular procedures. Also, it was seen from studies that most of the patients in cardiac ICU settings were not post-operative patients. Like, they were patients who had other cardiac issues such as acute coronary syndrome and other cardiac problems such as cardiac tamponade, etc. So, the cardiac anesthesiologist does not have much experience or does not follow up longitudinally. Right? They are more involved in the perioperative care, which is a very cross-section in care. If we look at the long-term outcome of a patient, that's all. Thank you.
Thank you, Nushna. And here is your product, Lisa. So the time has come actually almost 30 years. From last 30 years, anesthesia has now stepped into the wider territory and outside the operating room and extending their experiences in the ICU and taking charge of many of the ICU. But there are some lacunae definitely. In spite of being a cardiac anesthesiologist, I definitely think that the ICUs in future and the ECMO should be led by a cardiac anesthesiologist. But still, there is some loopholes in there in our knowledge, especially because managing an ICU also involves a very widespread knowledge about the antibiotics and the infectious disease management.
which is not incorporated into our regular cardiac anesthesiology curriculum. So I think our syllabus of the cardiac anesthesiology and also anesthesiology from the very beginning, now this is the time to amend that and incorporate not only 3 years OT duties and OT rotation, but definitely after 1 year learning of proper anesthetic management, we should be rotated into the heart medicine wards and the ICU for next 2 years, so that our ideas regarding the physiotherapy or the rehabilitation, then the nutrition, how to take care of the nutrition of the patient in the ICU, and also the infectious disease management, etc. And last but not the least, the communication with the patient's relative. That is very important in the ICU management by taking the leadership. Because when I am going to take the decision, then I have to communicate regularly with the patient party. As an anesthesiologist, many of the centers now they're doing it. But traditionally, it is not taught in our regular syllabus how to deal with the patient. Especially in the government sector, we really don't care about the patient party. Any of the patients, they keep on asking questions to us. We hardly, answer them. That should not be. There should be a counseling room where regularly, before every minor surgery, even they should be called and talk properly, so that what is going to happen next day. We should also care about the anxiety of the patient, what is going to happen. Especially, I think by that, we can minimize the thing that is the patient party and the doctor relationship into better future. And now I think what Ushna has told, you have something to counteract our points. Do you have anything to say? What do you think?
She's not wrong. But I think with time, what you said, so we should have some training must be there, like the hardcore general medicine, because we are too much centered in some areas, but not we have the holistic approach regarding the disease or the pathology. So after those,
ICU cannot be only the surgical ICU. All kinds of patients will come. So we will be really nervous while dealing them. So I think our bodies like IACTA, like I will say, they should now move forward to NMC. I don't know how much politics is involved there, whether they will allow the anesthesiologists to take charge of this bigger ICUs everywhere. Because this is a battle which Orpon is now fighting, and he is successful. Orpon, Dipanjan, and to some extent, I think Shoibal, they are the pioneer, they are the leaders who have shown us that yes, this position can be achieved. But time has come when it should be a proper, I think, it should be a move from our central bodies like IACTA. They should come forward with this kind of suggestion to the NMC that it should be incorporated into our curriculum. Otherwise, every time we will be second to something. That should not be there. Because they will not listen to us unless and until it is on pen and paper. The cardiologists, because all the other specialties, they also lack any of the qualities which is required for leading ICU, like airway management, like what he said, that the management of the hemodynamic monitoring. It's very important. Understanding the CVD technology and the physiology of ECMO, etc. That is not totally known by any of the other specialties other than us. But we should now come forward as a leader to lead the ICUs in not only in cardiac, not only in the ECMO or the post-operative surgical ICU, but also the cardiac ICU. Okay, why not?
And who will be the better leader? Because we are the bridge between the machine and the patient. So we handle the machines to give better physiology to the patient when they are anesthesia or the surgery is underway.
Unified this food, what is it? Carefully. What is that?
So multidisciplinary approach means the decision to the patient on ECMO, or what should be the further we should take the opinions of many different specialties. Like whoever is expert in whatever field. Like for example, the nutrition of the patient, we should take the help of a nutritionist.
That is fine. But we're talking about the decision making or the management. Is that the management to know? Okay. Decision making you also do. But you are not getting credit for that.
Yes. We are not getting credit for it, as well as we don't have the legal, I think we don't have the medical legal backing for it also.
Good point and coming. Medical legal, but Dr. Patil's this last one actually, as you have told, what is actually needed. See, he was a cardiac surgeon. Okay. And he put the first step in meconium aspiration syndrome in a 1-day-old child. So when a cardiac surgeon meets a meconium aspiration syndrome, is it a medical legal backup? Or is it a expertise matches over there anywhere? Nobody. If you ask your cardiac surgeon to put a cannula in the meconium aspiration syndrome, will you be even after 50 years after, is he agreed to put that? No. Because everywhere it is somebody's extra step has given medicine is a extra leap to us. So what he has told, that it is easy to look back and think that there was a brilliant plan, but it was not that at all. We started out to solve a problem, and then another, and then another. It was just a persistence and sticking with a problem until it was solved, with a big team of people, with some phenomenal researchers trying to keep people alive who were going to die.
So Bartlett had convinced the parents themselves.
No, there was no parent. The parent was a Mexican refugee. She just jumped the Bangladesher refugee mode. SIR এ পালাচ্ছে না তো ও পালিয়ে এসেছিল মেক্সিকোর বর্ডারটা ক্রস করে জাস্ট এসে এখানে মানে প্রেগন্যান্সিতে এটা প্রিম্যাচুর বেবিটা বর্ন হচ্ছে কোনো কনভিন্স কিছু করতে হয় সেদিকে রাত্রে ছিল লোডশেডিং ছিল অন্ধকারের মধ্যে ফাজে ছবিটা করে দেখা যাবে না ওটা দেখা যাবে অন্ধকারের মধ্যে গলাটা কেমন কোনো কনভিন্স কিছু করতে হয় রিফিউজি কনভিন্স করবে মা তো ছেড়ে পালিয়ে গেছিল স্প্যানিশের নামটা রেখেছে হচ্ছে নার্স স্প্যানিশ মানে হোক স্প্যানিশ তো এরিয়াটা স্প্যানিশ লোকেদের ছিল স্প্যানিশ মানে হোক নার্স গুলোর নাম রেখেছে মা হদিসই পাওয়া যায় কোনো পার্টি ফাটিকে কাউন্সিল করতে হয় ঠিক আছে বুঝতে পারি কথা only what he has done he has put one step ahead with একদিনের বাচ্চাটাকে আমি ক্যারোটিটা জুগুলারটা নিয়ে দুটো ক্যানোলা ঢোকাবো এই তো করেছে কথাটা বুঝতে পারছি আমরাও তাই করি that's what I do so don't think this everything will be given in your plate until you have asked for এই যে চারটে পয়েন্ট লিখেছো না সবকটা তোমাকেই করতে হবে nobody is going to give the medical legal backing ঠিক আছে আমি রবিএনসি একটা কেসে গেছিলাম ঠিক আছে আমাকে ওখানে জিজ্ঞাসা করা হয়েছিল তুমি কি ব্রঙ্কোস্কোপি করতে পারো তুমি কি ব্রঙ্কোস্কোপিতে তোমার কি আছে আর ইউ পারমিটেড টু ডু ব্রঙ্কোস্কোপি তুমি ব্রঙ্কোস্কোপি পারো পারো রেগুলার করছো ডাবল নিউমেন টিউব ঢোকাচ্ছ এমআইসিএস করছো এই করছো ঠিক আছে আই উইল আস্ক কোশ্চেন এবং হু আস্ক মি দ্য কোশ্চেন ইটস দ্য অ্যানাস্থেসিয়া অফিস উল্টো দিকে বসছিলেন ঠিক আছে আমি আই কুড নট মাই থিং যে না তোমার নেই তাহলে স্যার রোজ তো করছি যখন সার্জন চাইছে বাঁ দিকের লাংটা এমআইসিএস করে 2000 টাকা লাখ টাকা বেশি নিতে তখন তো ব্রঙ্কোস্কোপি করতে মানা করছেন না সো দিস ইজ দ্য থিং okay nobody is going to give the plate on you this thing so these four things what you have read this multidisciplinary approach is a bullshit ও যে ফার্স্ট লাস্ট এটা লিখেছে যে মাল্টিডিসিপ্লিনারি হতে হবে এক্সক্লুসিভ হতে হবে না ইট ইজ এক্সক্লুসিভিটি which comes too many people actually spoils the broth ডিসিশন মেকার সবসময় একজন হয় ঠিক আছে যদি বার্টলেটের অ্যানাস্থেসিস্ট সেদিকে বলতো যে আমি একমোটা দিয়েছি তাহলে বার্টলেটের নামটা মুছে দেব ও জোর গলায় বলেছে বলে দুটো ক্যামেরা ঢুকিয়েছে বুঝতে পারলে কথাটা অ্যানাস্থেসিস্ট কি করেছে ও কবে মেডিকেল লিগাল দুটো ক্যামেরা ঢুকালে কি হবে রোজ ক্যামেরা ঢুকাচ্ছে কিন্তু গলাতে সেটা লাইট করছে এগুলোতে একটু বড় ক্যামেরা ঢুকিয়েছে সো দিস ইজ দ্য থিং দিস ফোর কেউ হাত দিয়ে দেবে নাম্বার 1 সেকেন্ড হচ্ছে হোলিস্টিক ইন নেচার মানে হোয়াট ইজ দ্য হোলিস্টিক কি অল পয়েন্টস পেশেন্ট তো এসছে পেশেন্টের স্যাচুরেশন 50 ব্লাড প্রেশার কম ঠিক আছে সেটা প্রেগন্যান্সি হতে পারে সেটা 2 কেজি বাচ্চা হতে পারে সেটা একটা এএমআই হতে পারে তোমার কাজ তো ফাইনাল কমন পাথওয়ে তুমি দিচ্ছ ঠিক আছে ওয়াই ইউ নিড টু নো যে ডেঙ্গু হতে পারে কথা বুঝতে পারছো পরে যে সবাইটা তো দেখবে না 80% মর্টালিটি তাই না সো দিস ক্যানট বি হোলিস্টিক কারিকুলাম চেঞ্জেস হবে না ঠিক আছে তার কারণ হচ্ছে আমরা যারা মানে ইয়েতে আসে আমাদেরকে পোস্টিং করতে হয় তোমার রেসিডেন্ট কজন এগুলো মেপে মেপে করি আর মেডিকেল ইয়ার ব্যাকিং ইজ নট গোইং টু কাম আনটিল আনলেস ইউ আন্ডারস্ট্যান্ড এই যে ঘটনাটা বললাম আরেকজন ডাক্তার ওখানে ছিলেন যার এক বন্ধুকে আমি বাঁচিয়েছিলাম সে আমাকে তখন উদ্ধার করলো যে না স্যার এই মোটামুটি কাজকর্ম করেন ফ্রড নয় তার কারণ তার বন্ধুকে আমি কদিন আগে 78 দিন এক কোটি বার করেছি সো ইট ইজ দ্য অ্যানিকডট হুইচ আর গোইং টু সেভ ইউ আমি দেবাশিস লিখলো না এবারও বারো আর বার প্রত্যেকটা কেন আমি দিই তার কারণ হচ্ছে ইউ হ্যাভ টু ট্রাম্পেট ইউর ওন ড্রাম তুমি পড়ছো জানছে কি সবসময় আমরা বলি আমরা এর পেছনে পর্দার পেছনে আমরা তো আসছি না সামনে কে এনে দেবে কে পর্দাটা টানবে বুঝতে পারছো কথাটা অ্যান্ড অলসো এখানে যেটা লেখনি সেটা হচ্ছে ফিনান্সিয়াল চ্যালেঞ্জেস 50 লাখ টাকা বিল হলে 35 লাখ টাকা দিয়ে বাড়ি চলে যাবে 15 লাখ টাকা তোমার মাইনে থেকে কাটাবে এটা সার্জেনদের যায় ঠিক আছে ওরা বলে ঠিক আছে ওরা ওরকম একটা ইয়ে করে যায় তোমারও যাবে এবং তোমাকে সেটা হজম করতে হবে দিস ইজ দ্য ওয়ে পাথওয়ে ওয়্যার ইউ উইল গেট দ্য রেকগনিশন বুঝছো এটা হচ্ছে আই এম জাস্ট টকিং অ্যাবাউট দ্য থিংস হোয়াট আর গোইং টু কাম ইন ইউর প্র্যাকটিস এই পার্টগুলো is very much pertinent. It should be immediately included in the system. With infection control also, I have never seen any infections other than মানে তোমার mediastinitis. Mediastinitis এর মতো কোনো ইনফেকশন নেই কত খারাপ আমরা সেটাকে ম্যানেজ করি বুঝতে পারছো বাকি ইনফেকশন তুমি ম্যানেজ করে নিতে পারবে আর কি হচ্ছে নিউট্রিশন নিউট্রিশন তো ইজ জাস্ট এ রিডিং এন্ড গোইং থ্রু ইট এর মধ্যে কোথাও কিছু নেই এগুলো সবকটাই ফিজিওথেরাপি উই ডু মাচ মোর ফিজিওথেরাপি দ্যান আদার নরমাল আইসিইউ গাইজ ডাজ সো নলেজে কোথাও কোনো ঘাটতি নেই ঠিক আছে অনলি থিং এই চারটে পয়েন্টে ঘাটতি আছে বাট ইউ হ্যাভ টু ডু অ্যান এক্সক্লুসিভ লিডারশিপ আস্ক ফর ইট আনটিল আনলেস ইউ আস্ক ফর ইট নোবডি ইজ গোইং টু গিভ
So I'm asking IACTA actually. Every time a patient comes out from our should, when I said, you will see, those who are the members, CC members of IACTA, they should come forward because that is the way our name also should flow to the child.
The in charge of the ICU, who is the in charge of the ICU? বিকেলবেলা পার্টি মিট করলে পেশেন্ট মারা গেলে কে পার্টি এসে কাকে করবে এটার উপরে ডিপেন্ড করবে যে কে ওই আইসিইউর কমান্ডারটা
But Dr. Armanda said that you have to take a leadership. You have to take initiative. Initially, all the cases will come, but anybody has to take leadership, and problem will be gradually sorted out.
Yes.
যেটা প্রশ্ন সেটা হচ্ছে যে আমরা সবাই এই রেসপন্সিবিলিটি নিতে রাজি কিনা দ্যাট পেশেন্ট মারা গেলে we have to face the patient party and everything and the financial losses আমরা সেটা নিতে রাজি কিনা everyone যদি রাজি হয় আরেকটা is always there along with the cardiac anesthesiologist we are there always কিন্তু এই রেসপন্সিবিলিটি স্যার যেমন নিয়েছেন সেরকম অনেকে নিতে রাজি নয় completely so that is the issues and thing is that we have different fellowships এই যে প্রত্যেকটার উপরে ফেলোশিপ আছে নিউট্রিশনে আছে কার্ডিয়াক ক্রিটিক্যাল কেয়ারে আছে ECMO আছে বিভিন্ন রকম আছে সো ইফ ইউ ওয়ান্ট টু লার্ন সামথিং আমি এই মুহূর্তে কার্ডিয়াক ডায়াবেটিসে একটা ফেলোশিপ করছি তো তুমি যদি চাও শিখতে এভরিথিং ইজ দেয়ার তো ইফ ইউ ওয়ান্ট টু লার্ন দেয়ার ইজ আ লট অফ থিংস টু there is fellowships and every place is there where you can learn তো কোয়েশ্চেন ইজ যে তুমি সেটা চাও না চাও না only সকাল থেকে রাত অবধি অ্যানেস্থেসিয়া দিয়ে বাড়ি চলে যেতে চাই না have the guts to take the responsibility.
Also, sir, I would like to add on. So, like you said, like we have to beat our own drums. We have to like announce to the world that we are doing it. So, but when we have when we can go for further training, when we have further fellowships available, like ma'am said, why not go for this training? Why not improve our skill set and then do all of these things? That is the problem.
No, the problem is that I come to this fellowship that until NMC steps in, many of these fellowships, even the IACTA places, what we are not doing, that is not activated by NMC. That degree will not be recognized
ওদের একটা কথা বলছি আমার
medical council.
I know আমি একটা কথা বলছি আমি যার কাছে who was my guide ডক্টর অনুপম গোস্বামী স্যার আমাকে যেটা বললেন আমি তোমায় গাইড করতে কিভাবে পারবো আমি নিজেই তো ডিএম নই তাই না দিস ইজ নট দ্য থিং the court will see your experience in that specialized field কত বছরের এক্সপেরিয়েন্স আছে সব সময় রেকগনাইজেশন পেতে তো সময় লাগে না এটা will take time but it's not like that এই মুহূর্তে আমরা সেটা করবো না
What I'm saying that because ধর এখন ক্রিটিক্যাল কেয়ার আগে ডিএম ছিল ঠিক আছে নাও ক্রিটিক্যাল কেয়ার ডিএম হচ্ছে আর ক্রিটিক্যাল কেয়ারে ডিএম যদি কামস টু এ ক্রিটিক্যাল কেয়ার ইউনিট সে আই এম দ্য ক্রিটিক্যাল কেয়ার স্পেশালিস্ট তো আমি একটা কার্ডিয়াক অ্যানাস্থেসিয়া বহুদিন করছি ইভেন কার্ডিয়াক সার্জিক্যাল আইটি সে ইন আওয়ার আইটি we are managing I know we are capable enough doing great things এখন যদি একটা হসপিটাল care specialist can yes deem critical care obviously each authority will be final in medical council
না দাদা সেটা নয় তাহলে ফারুক সাদিয়াও কিন্তু ওটাকে বলতে পারবো না
আমি বলছি আর কি that's a great job
না আমি ওটা প্রশ্নটা হচ্ছে যে তুই মেডিকেল কাউন্সিল কারটা ঠিক আছে আমি বলছি যে প্রথমে তোদের জিজ্ঞেস করি একটা প্রোগ্রাম করতে এগুলো করে আমাদের লাভটা তুই বলছিস টিভিটা খুব সাংঘাতিক একটা এফটি ঠিক আছে এবার আমি ওকে ডাকলাম রাত্রিবেলা একটা জেনারেল আইসিতে একটা পেশেন্টের স্ট্রোক হয়েছে আমি বুঝতে পারছি না তুই এসে একটু টিভি করে দেখে দিয়ে যাবি এলে একটা ক্লট আছে দিস ইজ এ জেনারেল আইসিইউ ইভেন্ট একটা স্ট্রোক আইসিইউতে ওকে ডাকা ঠিক আছে ও কি আসতে রাজি or whether his reporting or her reporting will be validated or not because this is the indication তুই ওটিতে কটা টিভি করছিস আমি এখানে রোজ 5টা স্ট্রোক এখন তো স্ট্রোকে এসে গেছে টিভি লাগবে every stroke patient should have a alter and a টিভি
I asked this question to many
তুই আমি তোকে বলছি ও একটা সিএবিজি করিয়ে 5 ঘন্টা যদি 10,000 টাকা রোজগার করে 5টা টিভি করলে 25,000 টাকা পাবে is not even so why she is not coming in
That is okay, but will that allow her to take the leadership?
না সেটা বলছে লিডারশিপের ব্যাপারটা এটা তো হচ্ছে একটা তো জব অপরচুনিটি ঠিক আছে why a cardiac anesthesiologist is not able to enter in the system আমরা যারা এখানে বসে আছি সবাই তো ওই কেসটাকে করিয়ে এক্সট্রুবেট করিয়ে তাকে ছুটি দিয়ে বাড়ি যাচ্ছে সো হোয়াট মোর এক্সট্রা ক্রিটিক্যাল কেয়ার ইজ নিডেড সেই পেশেন্টের ইনফেকশন হয় তার ট্যাজাক থেকে মেরোপেনেম লাগবে না ডালমোভানসিল লাগবে সেটা তো আমি করছি আমি ঠিক আছে কিন্তু আমি বলছি আমার ট্রেনিং
and also financially share
এ বললো প্রেগন্যান্সিতে এ করিয়েছে পাবলিশ করলো হ্যাঁ কি বলে বলতে পারে প্রেগন্যান্সিতে আমি এ করতে পারবো না আমি জানি না প্রেগন্যান্সিতে মাইকেল হাল চেঞ্জ করে দিচ্ছে আমি প্রেগন্যান্সি জানি না
তো আমরা কাউকে বলছি না আমাদের যেটা এই সেশনটা বলছি একটু এগিয়ে আসতে হবে
প্রেগন্যান্সিতে মাইকেল হাল চেঞ্জ করে দিচ্ছে ঠিক আছে
ইউনিভার্সাল কোন মানে
বডি থাকা উচিত
different hospitals have different system
সেটা না একটু আমার মনে হয় ব্যাপারটা একটু আমি আউটার বাট আই এম টেলিং ইউ দিস ইজ গোইং টু হ্যাপেন ঠিক আছে আমাদের এখানে 17 জন ক্রিটিক্যাল কেয়ারের লোক আছে ঠিক আছে অল ডিএম এন্ড এভরিথিং ইজ দেয়ার কিন্তু প্রত্যেকের আলাদা আলাদা জায়গা আছে কথাটা কিন্তু বেশ এন্ড উই হ্যাভ আওয়ার ওন প্লেসেস অলসো আমি যেটা গ্রুপে লেখা যায় না অনেক সময় ইউ শুড থিংক দ্য এরিয়া আউটসাইড ইওর অপারেশন থিয়েটার অলসো when you are working there also you come to the normal ICU এই যে কলগুলো আসবে একটা ঠিক করার জন্য ডাকছি সৈকতটা করছে তো 40 ইকো করছে না রেগুলার ইকো কর কথা বুঝছো তোর স্কিল গুলোকে তুই লিডারশিপে পড়ে আসছে এই তাহলে তোকেই ডাকবে তুই মেয়েটা আছে ডেকে ও তখন দেখবে না তুই ক্রিটিক্যাল কেয়ারে ডিএম করছিস না ইউনানি মেডিসিনে ডিএম করছিস ও তোকে ডাকবে না দেখবে না ও ওই মেয়েটা এসে রাত 12টার সময় থাকে এটাও একটা অ্যাভেলেবল So this is the thing where you have to ask. এই 4 নম্বর 5 নম্বর গুলো আস্তে আস্তে উঠে আসবে মেডিকেল যদি শুধুমাত্র 11 কোটি টাকা মানে ইয়ে হতে পারে মেডিকেল কেউ দেখা দুদিকে যে বসে আছে তার ধারণার উপরে পুরো মেডিকেল চলে তাহলে ও কোনো ওইসব এতে দেখ এটা বললাম এগুলো বলছি আস্তে আস্তে বুঝতে পারছি আই এম নট ইউ বাট ultimately days have come you have to come out otherwise কি হবে ডিপ্রেসড হয়ে যাবে ঠিক আছে and very যখন মনে হবে এ বাবা টিএম কারে কেন সেটা কারে
কোথায় ম্যাডাম কালকে আমার সাথে
সেটাই দরকার ওইটা এরপরে লাভ নেই। আর ওই যে আগে যে দেবাশিসের কথাটা যেটা বলছিলাম, ওই মানে পিএ সব বেড়ে বেটাকে ধর পিএ ক্যাটারাক্টটাকে ধরেছে, ঠিক আছে, ওটা দিয়েই 2000 টাকা দাম পাওয়া কিচ্ছু হয় না, ওটা দিয়ে কোনো এও হয় না।
আমাদের একটু স্ট্রং থাকতে হবে স্যার, আমি আমরা আমার একটা লাভ
এখানে সন্দীপ স্বাস্থ্যসাথীতে মিনিমালি ইউজ করছে স্বাস্থ্যসাথী, তুই 2000 টাকা পিএ ক্যাটারাক্টকে পাচ্ছিস, তুই ভাবছিস আমি খুব সার্টিফিকেট is actually
একদম ভালো লাগবে না। কি বস্তু কাটিয়ে করতে তোমাকে এই করতে হয় না, মিনিটে গ্রাম হয়ে যাচ্ছে, বসে থাকো দাঁড়িয়ে থাকতে পারবে না ওকে পাহাড়ে মতো যাচ্ছে।
আর জায়গা
ডিসকারেজ করছি না,
ওর যে স্কিল আছে সেটাকে অন্য জায়গায় এ করো।
Recognized by the system or not? Time has come when really we have to beat our own problem.
সিস্টেমটাকে আমাদেরকে কনভিন্স করতে হবে, উই আর দ্য পারসন হু ক্যান চেঞ্জ দ্য সিস্টেম।
এদের হাসপাতালে থাকিস না, ওদের কেউ যদি জানে একটা কার্ডিয়াক অ্যানাস্থেসিস আছে, রাত 12টার সময় একটা নিউরোনাল আইসিইউ তোকে লাইন করতে কাটবে, তুই ওখানে হ্যাঁ বলবি না না বলবি এটা ডিপেন্ড, এইখানে এ করতে তুই তোর পরে লিডারশিপে যাবি, তুই বলি না স্যার আমার আপু অর্ডার হয়ে গেছে আমি যাবো, আর তুই যদি গিয়ে করিস নাও কথা বলছি।
আমি অ্যাকচুয়ালি হসপিটালে ছিলাম, নাইট ডিউটি করছিলাম ক্রিটিক্যাল কেয়ারে। তো নিচে একটা পেশেন্ট এমার্জেন্সিতে এসেছে, কেউ টিউব পড়াতে পারছে, ঠিক আছে। তো এবারে যেটা দেখা গেল যে অন্যান্য যে সমস্ত ডাক্তাররা সেই রাত্রেবেলা ডিউটিতে ছিল, তারা এমন খুঁজিয়ে রক্তাকার দাঁত ফাত ভেঙে একাকার করে, ঠিক আছে। এইবারে সেই মুহূর্তে আমার ডাক, যেহেতু আমার ব্যাকগ্রাউন্ডে একটা অ্যানাস্থেসিয়ার ডিগ্রি আছে, যে অভিজিৎকে ডাক। তো আমি যখন গেলাম তখন দেখলাম যে লোকটা যেটা আছে স্টিফ নেকটা উঁচু, পরে জানলাম নাকি অ্যানকোলজিস স্পন্ডিলাইসিস রয়েছে, স্যাচুরেশন ছিল 64%, সেখানে একটা অ্যাড্রিনালিন রাশ করার মতো সিচুয়েশন। আমি কি করলাম, তখনই একটা পারকিউটিনিয়াস ট্র্যাকেস্টোমি করে দিলাম, করে পেশেন্টটাকে বাঁচিয়ে দিয়েছি। তো এরপরে কি হলো, আমাকে আর কেউ ওই রকম ভাবে ডাকে না, কিন্তু সবাই জানে যে এয়ারওয়ে প্রবলেম হলে অভিজিৎকে ডাক। এমনও হয়েছে
সবাইকে আছে সবসময় চাইবে পর্দার পেছনে রাখো, ডাকবে তোকে, এই বলে ডেকেছে, ও 5-6টাও এরকম কল, তোকে তখন যেতে হবে, তোকে বলতে হবে আই হ্যাভ ডান দিস। আমরা দেখি ম্যাক্সিমাম আলোচনা যখন করি, আমরা সবাই আলোচনা করি যে তোর সার্জেন 8 ঘন্টা বিটা করে দিয়েছে, তোর সার্জেন -5 মিনিটস ডিমান্ড রিটা করেছে, এই নিয়ে আলোচনা করি। কিন্তু কখনো বলিস না আজকে একটা 150 কেজি পেশেন্টের ইনকিউবেট, একটা 120 কেজি প্রেগন্যান্সি স্পাইনাল, এগুলো নিয়ে আমরা আলোচনা করি না। উই টক অ্যাবাউট আওয়ার সার্জেন্স, উই ডোন্ট টক অ্যাবাউট আওয়ার থিং। এগুলো চেঞ্জ করতে হবে। This is the thing where we have to. So, what I বললাম কিন্তু, but what are you doing? You should publish and should come in front of. Nobody is going to do all this for to you in your claim. এখন কাটছর পাবলিশন। এই যে সেকেন্ড হচ্ছে আরো আরেকজন দেবে না, সেটা পারফিউশনিস্ট আর কামিং এর ক্লিয়ার হয়ে, তো ডাক্তার ছেড়ে দিই, মেন ক্রিটিক্যাল কেবল ছেড়ে দিই, পারফিউশনিস্ট তোকে এই জন্য এই করতে, তখন এটা আমাদের সমস্যা, আমরা চালাচ্ছি।
Like for the child, cartilage can be correct surgeons. Think the cartilage correct surgeons. So everything a common factor থাকে। তো it depends on the institution বা তুমি যেমন করে নিজেকে করতে পারবে, কোন ইনস্টিটিউশনে করবে।
কিন্তু এরা ক্রিটিক্যাল কেয়ারে আসে, আমি পার্সোনালি বলছি we are far better critical care physicians than others. ওর কাছে দুটো জিনিস, এয়ারওয়ে আর ভেনাস অ্যাক্সেস, এই দুটো নিয়ে তোর কোনো টেনশন নেই। বাকিদের প্যান্ট হলুদ হয়ে যায়। আমি দেখেছি তো একটা ফিজিওলজিক্যাল ডিফিকাল্ট দেয়ার হতে 54% এর বাইপাপে হাঁপাচ্ছে, ইনকিউবেট করবো কি করবো না তোকে ভাবতে হয়, পরের হ্যান্ড ওভারটা এলে পরেরটাকে দিয়ে পালিয়ে যাবো, ঠিক আছে। ওখানে তুই তো দাঁড়িয়ে বললাম ঠিক আছে ভালো করে ভেন্টিলেট করে টিউবে ঢুকি, so you are the boss, you know, everybody will, কাজের মাধ্যমে তুই বস, আর যে কোনো জায়গায় লাইন করতে পারিস, সুপারভিশন টেম্পোরাল আর্টারি লাইন করে দিয়েছে, হ্যাঁ করেছে, কিন্তু না নেই।
Actually, one of better acute care specialists than
not a single person. At the same time, when we know we are the boss of the airway and lines and all, considering all these things, to be recognized that good critical season, we teach properly even for the country, everyone accomplish. So you need also need to down the other.
Yes. We have to extend our
in a dominant manner.
দেখ আর একটা যারা বস জাতি নেতা বল এই বস সবাই কিন্তু একটা ইনস্টিটিউটের মাথায় বসে আছে এরাই ব্যাপারটাকে ইমপ্লিমেন্ট করেনি এখন ওই সাই 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 করে দিই তবে এখন বলেছিলাম এটা যদি আপনারা কেন এই করছেন
Notes to the data sheet, board everywhere. But till now,
অনেকে ইন্টারেস্টেড নয় এইটাই হচ্ছে ব্যাপার যেটা আমরা নিজেরাও ভেবেছিলাম যে এই ব্যাপারটা নিয়ে আরো আমরা আরো ল্যাবরেটরি একটা সার্ভে
করব এমআইসিএস কি একটা ভালো অ্যানালিসিস করা সম্ভব
ডেফিনেটলি নয়
এমনি কেসটা তাও টেকনিশিয়ান প্রসেস এমআইসিএস সম্ভব
সম্ভব নয়
আর দেখা যাচ্ছে না কি এই ক্যামেরাটা চলছে পেছনেরটা কেসে পড়ে আছে কখন কি হচ্ছে চলে গেছে উল্টো দিকে চলে গেছে
সিএম এর পার করতে হচ্ছে দিস ইজ কমন সো সেটা যেটা বলার যে লিডারশিপ মানে এগিয়ে আসতে হবে স্যার যেটা বললেন বলতে হবে যে আমরা এটা করছি এটা কিন্তু করতে হবে প্রত্যেক না বললে হবে না
any for what organized training it could be but one thing which I want to mention is what Madam told in her version the last comment is that communication part it is very very important communicate with the relatives communicate with the management for the financial burden for the expenses the outcome communicate with your colleagues it's not how these are the reasons a leader can be born knowledge of airway knowledge of hemodynamics knowledge of antibiotics even could be taught but how to become a leader cannot be taught and I think from the initial days apart from these areas of expertise like the medical background the clinical knowledge how to become a leader we should think about it should learn then only we can be vocal we can raise our voice what we have done
yes of course COVID is the only time I think when the anesthesia came into the life there. Okay, so thank you, Melissa.
Thank you for the explanation. Thank you very much, Kapilini, Officer, everyone. Thank you for your active participation. So we will move on our next session. That is the early extubation in the operating room should be routine after adult and pediatric cardiac surgery. The session will be moderated by Dr. Soumitra Mukherjee. He is one of the excellent teachers I know. Soumitra, stage is yours.
So, good evening. The attendance has been reduced. Which was it? Hey, post board. Anyway, so let's come to the present debate topic. That is the early extubation in the operating room should be routine after adult and pediatric cardiac surgery. So we are in an era where we have pushed our boundary from faster extubation to extubation within the operation theatre even after the cardiac surgery, whether it is adult or the pediatric one. So we have two speakers. With the motion will be led by Dr. Valikana Subramaniam. She is a first year DM student in NRS Medical College, and Dr. Anmol Singh, he will be talking against the motion. He is a second year PDT of IPG EMEA. So good luck, all of you, both of you. Let's start. Dr. Valikana Subramaniam, please.
evening. Early extubation in the operating room should be routine after adult and pediatric cardiac surgery. I'll be speaking in favor of this. So when we talk about recovery after cardiac surgery, the goal is not simply survival, but also a smarter recovery, faster mobilization, and fewer complications. The early extubation is commonly defined as extubation within 6 hours after cardiac surgery. It is well established that early extubation improves the quality of patient recovery and decreases the resource use and healthcare costs. However, immediate extubation in the operating room after cardiac surgery remains a controversial and infrequent practice. So in this session, we'll discuss the pros of extubating in the operating room with the aid of few studies which prove the safety and efficacy of the OR extubation in adult and pediatric cardiac operation. Subramaniam and co-workers conducted a study on predictors of operating room extubation in adult cardiac surgery. The primary aim of their study was to identify if perioperative factors are associated with successful immediate extubation in the OR. And their secondary objective was to derive a simplified predictive scoring system to guide clinician in the OR extubation. So their study was a retrospective cohort study based on the STS database of cardiac surgery. It was conducted in a single hospital setting, and they used a multivariable logistic regression. So they had two set of patients. One was a derivation set of 800 patients who got extubated in the ICU successfully, and the other set of patients, a validation set of patients, 398 patients were included in this. They were the patients who got extubated successfully in the operating room. So with the help of this derivation set, they found out if the high factors which were high likely to result in successful ICU extubation, they gave a high positive score. So as we can see in the table here, age group of 40 to 49 were given a positive score. BMI less than 25 were also given a positive score. Whereas diabetes was given a negative scoring, urgent surgery was also given a negative scoring. So they implied this scoring system on the validation set of 398 patients who underwent extubation in the operating room. And a strong association was found between the high positive score and successful extubation in the OR. So as we can see in this bar graph, so what the study told was that patients who had a positive score more than 5 were good candidates for extubation in the OR, and patients who had score of 0 or less than that were not considered to be good candidates for extubation in OR. And those who were between the scores of 0 to 5 had a possibility of extubation in the OR, but it was based on the clinical judgment of the clinician. So the results of the study were younger age, lower BMI, higher perioperative albumin, absence of chronic lung disease and diabetes, and less invasive surgical approach, isolated CABG, elective surgery, and lower doses of intrafentanyl were independent factors associated with higher probability of OR extubation. So another study, Timmon and co-workers did a study on operating room extubation for patients undergoing cardiac surgery. So this surgery gives us an insight if it makes a difference between fast-track intubation and OR extubation. So the background of the study was to assess the utility of operating room extubation after cardiac surgery over the fast-track extubation within 6 hours remains contested. So this was also a retrospective cardiac surgery based on STS adult cardiac surgery database. It was conducted in a period of time in multiple hospital settings. So based on this, the 4 major outcomes that was analyzed in the study was post-operative mortality and morbidity, re-intubation or re-operation, and prolonged length of stay. So all these outcomes, as we can see, the O/E ratio was less. That is, they were less likely to happen in the ORE group and more likely or slightly likely to happen in the FTE group. So the conclusion was that extubation in the OR was safe and effective in selected patient population. and may be associated with superior outcome in CABG, AVR, and NVR patient. So this table that has been put up shows the intraoperative characteristic of patients extubated in the ORE and FT. As we can see, the patients who underwent extubation in ORE had a less cardiopulmonary bypass time, less cross-clamp time. Whereas those who got extubated in the FT had comparatively more CPP time and cross-clamp time. So this is another study done by Gar and co-workers. So this was a prospective observational study. This was undertaken to determine the feasibility of extubation in children in the operating room. So they had a study group who underwent 1,000 patients who underwent extubation in the OR, and before study group who were not extubated in the OR. Again, the results were 87% of the patients could be extubated in the OR, which included neonates and children less than 1 year. So again, they concluded that extubation in the OR was successful, and it doesn't increase the morbidity or mortality, but decreases the ICU length of stay and hospital resource utilization. So based on the previous, in concurrence to the previous researches, the benefits of extubation in the OR were better hemodynamics and less inotropic support. So positive pressure ventilation basically increases the intrathoracic pressure, causing decreased venous return and preload. It also increases the right ventricular afterload and decreases the left ventricular afterload and stroke work. And it also avoids pulmonary and airway complication associated with intubation, and also reduces the use of sedative and paralysis, so which are known to cause delayed neurodevelopmental outcomes in childhood when they are exposed to more amount of sedatives. And also it reduces the length of ICU and hospital stay. So the risk factors that were commonly associated with extubation failures were, so patient risk factors were presence of major preoperative risk factors like hepatic dysfunction, chest compression within 48 hours before surgery, neurological renal deficit. Anesthesia risk factor were usage of higher doses of intraop fentanyl, more than 20 mics per kg, more amount of transfusion of blood and blood products, and inability to maintain fluid balance, and longer acting inhalational agent in post bypass. Surgical risk factors were those associated with longer time of CPB, aortic cross-clamp time, residual cardiac lesion if not recognized early, delayed sternal closure, and RACHS score more than 3. Post-operative risk factor, prolonged post-operative ventilation itself led to extubation failure. So the prerequisites for implementation of early extubation in concurrence with the previous studies were to develop a proper protocol based on the clinical judgment and resource setting in an institution, like regional anesthesia technique, multimodal analgesia, and a multidisciplinary approach, a team approach with a dedicated team of cardiac anesthetists, surgeon, perfusionists, and ICU team. Patient consideration. So we should avoid immediate extubation in OR, patient who have major morbidity. And surgical consideration, avoidance of patients who underwent long CPB time, cross-clamp time, deep hypothermic circulatory arrest, bleeding, residual cardiac lesion. So intraoperative goals and management, attention should be paid to fluid balance, like removal of excess water with modified ultrafiltration, conventional ultrafiltration technique, limiting exposure to blood products like usage of antifibrinolytics like tranexamic acid routinely, and pain management like we can use caudal analgesia wherever possible based on the coagulation profile in children, and in adults we can follow regional anesthesia like paravertebral block. So all these reduces the usage of opioids. And anesthesia technique, so good surgical repair, which can be assessed by routine intro transesophageal echocardiography after the surgical repair, and hemostasis and preservation of organ function to ensure hemodynamically stable patient who's awake, comfortable, pain-free, and able to breathe well by the end of the surgery. Post-operative care, good analgesia, and availability of any one of the non-invasive respiratory support to prevent re-intubation, like CPAP, high-flow nasal cannula, and high-flow oscillatory ventilation. So, conclusion, in concurrence to the previous study, I would like to conclude that immediate extubation is safe and should be practiced more broadly in selected patients wherever feasible with advancement available in cardiac anesthesia. So, when done systematically, it enhances recovery, reduces complication, improves patient and family satisfaction, and optimizes resource utilization without compromising safety. Immediate extubation also does not prolong the duration of time spent in the OR if appropriate anesthesia technique is used. And OR extubation, on comparing with early extubation and ICU, should reduce length of stay, thereby cost saving with improved patient satisfaction and comfort, and avoidance of unnecessary sedation medication, and maintain better hemodynamic in awake spontaneously breathing patients. These are my references.
Thank you, Dr. Subramania. So, she has discussed in favor of the house. Now, Dr. Armal will be talking against the motion. Please, Dr. Armal.
Good evening, all. First of all, I'd like to thank my colleague right here and the one who spoke for the pro. She's beautifully summed up the points that I was going to speak in the extubation failure. So it'll save all of us some time and the 10 to 12 people who are here paying such great attention to the talk. I am really indebted that you're staying back from the tea and watching me speak. As we go, we start with primum non nocere, the first principle of medicine and most important line in Hippocratic Oath. As we say, first do no harm. And extubation is an art. And that fine art is a fine balance of finding where harm occurs. And here I'm speaking against the motion for on-table extubations for cardiac surgical patients. So various definitions of extubation types: immediate extubation, early extubation, and late delayed extubation, where within 6 hours is strongly recommended by STS, and any extubation beyond 21 hours of the surgery is associated with high mortality, morbidity, and poor outcomes in terms of failure to treat as well. And as we can see, the very recent IDA guidelines that have come out this very month are proposing SAFE as the mnemonic for at-risk extubations, which most of our patients are, if we believe hemodynamically as well as physiologically. Airway, on the other hand, maybe our oncological colleagues are seeing more. Yes. So we see the readiness for on-table extubation is a 4-layer framework where we need to see the airway ventilator mechanics, the hemodynamics and perfusion, the system and resources, and neurological sedation and outcomes according to that. Out of which the most important thing is a variation in the teams that we all have. A hospital to hospital variation, interdepartmental variation, a variation between 2 different consultants can change the management of the patient and hence the outcome and hence the course of extubation of the patient. Here, as well as we need to take a tailor-made approach for the patient, no single routine protocol is to be followed in 2025. Every patient deserves a tailor-made approach to their healthcare in terms of anesthesia, surgical management, or otherwise. And yes, of course, there are key post-CPV factors that we are dealing with that our anesthesia counterparts, the broad specialty anesthesia counterparts, do not deal with. So we have myocardial stunning, residual bleeding and coagulopathy, elevated lactates due to hypoperfusion, vasoactive inotrope dependence, which are relatively higher, which are more commonly used by us than our broad specialty colleagues, and uncertain neurological status and respiratory compromise secondary to the hemodynamic collapse. And yes, of course, we can talk about OR extubation on the other hand, with the evidence of early extubation improving outcomes when applied, but those outcomes are only improved in terms of extubation within 6 hours, not immediate operating room extubation. And yes, it is a case-to-case variation and not a one-size-fits-all kind of a situation. And we can see that the summary of the whole situation is that we have to do everything with subtle caution and care tailored to the patient. And yeah, as we can see, Andrew Hawkins et al., the operating room versus intensive care extubation within 6 hours, OR extubation is associated with a higher post-operative risk of intubation and re-intubation and re-operation due to bleeding because of the sympathetic surge, because of the multifactorial causes that may lead to patient deterioration and hence cost us more than the 24 hours initial that would have been supplemented into the patient's stay by extubating within 6 hours. The 2 minutes extra that my colleague here talked about by extubating in the OR will cost us more than 48 hours to 72 hours in the ICU, which will cost the patient somewhere in the ballpark of 6 to 8 lakhs in a private setup. And yes, a different extubation protocol for adult cardiac surgery at systematic review of 1454 patients, late extubation was significantly more effective than immediate extubation strategies. And with a relative risk of 1.52% and a 95% confidence interval, the p-value was more than significant with a p-value of 0.00001. And the findings indicated that the late extubation strategy is substantially higher rate of extubation and a better outcome rather than giving immediate extubation. Also, we can see here that in this study, in relatively large study of 24,962 patients, the outcomes were significantly better in patients that were extubated later on. And the risk and re-intubation was higher in the patients extubated in the operating room. I think that speaks volumes about extubating in the OR as a way to hush up things. And I believe you can also say there is no safe conclusion to be drawn about the benefits due to high heterogeneity found in the studies that predict a better outcome in on-table extubation. The methodologies are more often flawed, skewed, and very biased in the studies that profess on-table extubation. And yes, clinical variables specific to timing of tracheal extubation following pediatric cardiac surgery, the RACS1 score and the STAT category and the VIS are very important here. And for longer CPB runs, we need to take care of the patients and not follow a certain routine protocol of extubating on table, though it might be one of the options. Yes. A retrospective multicentric study here again points to the same things that we have patients who are extubated in the OR had longer OR times, 5.6 versus 5.1 hours, greater rates of reintubation of 5.2%, prolonged ventilation of 3%, reoperation due to bleeding, pneumonia, and greater in-hospital mortality with a significant p-value. And mortality is one of the metrics every corporate hates, every government hates, and every senior hates. I'm very sure about that. And yes, we can see failed extubation, a source of increased mortality, is a testament for how worse it will be to extubate in the OR after going through such a major hemodynamic shift, a major cardiac surgery, a surgery which involves bringing the patient out of deepest of sedation with high opioid use. And even if the opioid use is reduced, the amount of fluid shifts and the amount of hemodynamic instability that the patient goes through is significant enough to worsen the outcomes if we hush up the extubation. Yes, and our protocolized patient-centric, safety-oriented, multidisciplinary care is the goal of every ICU we know. Every ICU, every physician, every doctor has to follow a patient-centric approach. And this is what we provide when we give a late extubation or a fast-track extubation within 6 hours, rather than hitting it on our egos and going like, I can extubate it today, I can extubate it now. So yeah, so the goal is to reduce ICU length of stay. The goal is clinical readiness over time. The goal is multidisciplinary protocolized approach. The goal is to standardize criteria and individualize care. And the goal is to continue team communications, because we as anesthesiologists from day one are taught to be team members and team leaders. Our first tenet is call for help, which is a part of being a team. And yes, the extubation failure in pediatric cardiac surgery again shows fairly poor outcomes when extubating in the OR. And again, another study here, it's a large consortium. It again shows and replicates those results. Yet again, my point here is let your healthcare be tailor-made. Provide the care you wish for, and evidence-based care which is unbiased and safe. And most of all, slow and steady wins the race. So yes, of course, there is a funny little character in Cowboy Bebop that I love to quote a lot. You have to be fluid. You have to be fluid. You have to be like water, which is inspired by Bruce Lee. So you keep on changing, but you hold to the principles that you were so daringly clinging on to. Patient safety and patient-centric approach. Thank you so much. Let the rhythm of the recovery, not the clock, decide whether your patient breathes on their own. Thank you.
Thank you very much, Dr. Anwar. So, thank you very much, and thank you, Dr. Subramaniam. So, really, it has been proven that fast-track extubation is now an ideal approach. Now, whether we will come forward, will go beyond our routine practice of fast-track extubation into routine extubation within the operation theatre. As far as in favor of this motion, what Dr. Subramaniam has already shown in her lecture is that there is a publication in Annals of Thoracic Surgery. They did one survey where the number of patients was more than 6.5 lakhs. They did their survey in more than 1,000 centers. 1,069 center is the actual value. And they do agree with their analysis that for the adult cardiac surgery, routine operation room extubation can be done, provided some safety measurement has been taken, which has been discussed very well by Dr. Subramaniam. And there are certain scores also. It was published in the year 2017 in DCVS that the score is the prediction score of operation room extubation. If it is more than equals to 6, then we can easily extubate within the theatre, and that's all. But as far as Dr. Anmol's concern is being concerned, case, we have to choose the situation, we have to choose the patient. It should not be a routine protocol for every patient to extubate within the theatre. So according to the situation, according to the patient's characteristic, we can follow the operation room extubation protocol. The short note that in situations where we should not go for routine extubation, almost both of them have discussed all the points, all the concern points. Just I want to mention the situation where operation room extubation is not helpful at all. Number one, patients with airway swelling, like difficult airway, there will be airway edema because of prolonged surgical duration. Next is the significant hypothermia. Do not even try for extubation within the theatre. First, warm the patient properly. Even after open surgery also. Then abnormal ABG. Do a routine ABG before the weaning within the theatre. If either the respiratory or the metabolic or both of them are abnormal, do not go for extubation. First correct the pathology or the abnormality, then go for weaning. Then high requirement of vasopressor and inotropes. That means that your heart is not ready for the extubation theatre. Then if aneurysmal intubation is required prior to the surgery, that means for any reason, maybe patient crashed in the preoperative period or patient was having heart failure, for that patient need to be intubated preoperatively, do not go for ORE. Then mechanical circulatory support if it is required in post-surgical period. Suppose you do one on-pump CABG, facing difficulty on weaning from the CV bypass and you need to put an IVP. Do not go for routine OR. Then if you are weaning a patient within the theatre, everything is okay, no problem in the intra-period, preoperative, all the characteristics are matching. But if there is starting and sustained elevation of the filling pressure during your weaning, cancel your or postpone your weaning planning within the theatre. And lastly, during emergence, if you are saying that patient is having acute hypercarbia and it is not getting corrected by any means, then again go back to the ventilation and then you do a faster extubation. So these are the situations where we can follow the routine extubation, and certain indications are also there where we should not follow. For the pediatrics, mostly the literature or the publications, they are telling that better to do extubation within the ICU. For the pediatrics, even after Fontan or the BD surgery, do it within the ICU. I mean the faster extubation. For a patient who is having severe PH or complex congenital surgery, no chance of even following the faster extubation also. So for adult, yes, you can follow. For pediatric, it is better to do in the. Thank you.
Any question from anyone?
There is hardly anyone to ask.
Everybody.
Or
Speaking. Yeah. One question. For any whether extrusion on paper, it is external time or the. So you are expecting one person on table. So whether extrusion on table. Okay, I see. Or research time real.
Study was done
cardiac surgery.
One pediatric cardiac surgery, 1,000 and it means 71 patients. Compared to the study book, that was the time they were not extrapolation. That was also 1,000. So when they compare this study group with the before study group, they found that the length of stay and discharge between the two groups, there was a difference of 1 to 2 days, which was a huge cost saving measure.
Right, that is 36 hours, right? So, maximum 6 hours.
I'd like to refer to my slides again. I'll just show you the slides.
Okay, so there is a clear comparison between operating room extubation and passive extubation with four parameters. Number one, the post-operative morbidity. Number two, ICU length of stay. Number three, hospital stay, and number four, cost stay. So all these four parameters we consider the operating room extubation or ratio is in favor of operating room extubation in comparison to the hospital. Has been, but obviously not everything. Not everything. Not everything. If the criteria matches.
No, I just wondering that 6 hours.
Actually, I had also no idea that
This was 2021.
I'm also
It's right there. I don't even have to speak. It's right there. Yeah, so 100 failed extubations, 5.8%, multivariate access, p-value is significant, and 503 patients were intubated and extubated in the cardiac operating room, and 15 people, patients, like 3% is a significantly big number. 3% is a huge number of failures. And they did have a significantly larger length of stay. These are all pediatric patients we are talking about. So one child lost is a bigger loss than any adult loss who's gone through their major chunk of life. And again, for even adults, I could refer to the studies here. So not looking very promising. 6 hours is a good compromise to take. Better safe than sorry. If you, yeah.
Being it in the OR or within 6 hours, only if it is proper multidisciplinary approach from the surgeon side, they should be proper, like they should reduce the CPV time, they should reduce the cross-clamp time, and they should achieve proper hemostasis. So in the study quoted by current co-workers, they have even extubated patient on truncus arteriosus repair, provided that proper hemostasis is achieved. So be it FTE or ORE, a proper multidisciplinary approach is required. So when it is not being followed, only the intubation rates increases, I feel.
Yes.
2 points to be mentioned over here.
This supports your
The
point.
multidisciplinary approach. Number one, rehabilitation. Proper rehabilitation, proper nutritional balance and nutritional encouragement and nutritional assessment, and proper nutrition should be there before ORE. And number two is the adequate physiotherapy team.
So coming from an onco-anesthesiologist to an ex-onco-anesthesiologist, still in love with the branch. I have a fellowship in that from Tata itself. So yes, I absolutely agree with you. Rehabilitation is the name of the game. I am thankful that you brought it up.
Just want to add something from my experience. We are doing endoscopic cardiac surgery just now. So there is 2 terms, that is early, that is fast tracking extubation, that is 6 hours after the surgery, after shifting of the patients. And one is a newer term is ultra fast tracking, that is 2 hours after shifting. So we used to do the ultra fast tracking, that is we wait for the 2 hours to have any complications like bleeding. So if there is no bleeding, patient is stable without any significant iron drops, we used to go with the extubation. Okay, so I think this has to be the essence of the endoscopic or robotic cardiac surgeries to fast tracking to ultra fast tracking the whole thing. Okay.
It's not only for the cardiac surgery, if you look for the whole spectrum, it is a shesh. There is a new term called means. Probably last time Monalisa has talked about that thing, means myocardial injury after non-cardiac surgery. So every extubation is actually a cardiopulmonary exercise testing. Every extubation, may it be in the critical care, may it be in the post-operative period. Now, if the person is not properly cardiac and pulmonary, this whole part is not properly optimized, is cardiopulmonary exercise testing through this, it will fail. So, not only the cardiac surgery, the many cases in case of means or other things, or PMI or means. So, all over there, if it is a big case, if it is a esophageectomy, so it's a big case, you know, probably. Whipples, it's done at least in my center, it's every day done 3 or 4. Okay, so in medical college, if one from oncosurgery, one from gastrosurgery, 2 is from the general surgery, like this thing. If it is a esophageectomy is not routinely done in every center or like any big cases. So it's like a cardiopulmonary exercise testing, may it be there or may it be there. Okay. So that's my point. It should not be hurried. When is the earliest time? Now this is the era of coming of the SOGA models. It's be early. It's very early to comment on SOGA models. After many years and years of use of pantoprazole, it came out to be a risk factor for to be out a cardiac risk or a risk for osteoporosis or other things. And now it has been mandatory in US to write it down over the PPIs that it causes AKI. Yes, it causes AKI. So it's very early to talk about Sugammadex. So just like that.
Even for Sugammadex, it's come up that a lot of sudden cardiac death cases have come up.
Yeah.
Recently, fairly recently, in the last 3 months, there's so many reports of sudden cardiac death.
And anaphylaxis. And
not just anaphylaxis.
Sudden cardiac
death. To do sudden cardiac. I don't know, unexplained sudden cardiac death.
I just yesterday I shared one article in the ASA of the anesthesia that occult hypoxemia once in the operative time, the SpO2 is good, but the SaO2 is less. SpO2 is showing 94, 95, but whenever we are doing an ABG, the SaO2 is coming 88, even less. And just like the hypoglycemia, once in a lifetime, a occult hypoxemia during the OT or whatever we mean, increases the mortality for the lifetime. That has come, the reports. So that is the thing. That is the thing we have to remember. There is nothing to be hurried. All is good. Good outcome. Thank you.
The multidisciplinary approach of Suryo has mentioned. This is very good.
One last. I would again like to point out, I'm sorry I'm taking too much time, but yes, the same thing, since we are always talking about DAS guidelines, this guideline, that guideline, Australian guidelines, the Indian guidelines here itself are mentioning all patients cannot transition from tube dependency to normalcy in a single step. This very month. So yes, they are very much aware of the situation. And it's not a single step process. It is a multidisciplinary focused approach that is tailored to the patient.
Definitely. Very good discussion. So we are moving. Just a question, Monalisa. Since we hardly meet, I take this opportunity to ask you, what is your plan since you're doing endoscopic cardiac surgery? What is your plan for pain management and when you're doing ultra-fast? How do you?
Yes, the beauty of the endoscopic cardiac surgery is there is no tissue retraction. We are having 3 or 4 ports and we are doing it through camera like laparoscopic surgeries and there is no tissue retraction. So pain is very less. We give only intercostal nerve blocks and the paracetamols. That suffices. Usually we have a recent study on that because we don't have faced any kind of major pain during endoscopic cardiac surgery.
Okay, if there is no questions, we will go to the further discussion with a very interesting topic. This is the last but not the least topic of this CME. Is it ethical to proceed with the elective cardiac surgery in elderly patients with good prognosis despite of high anesthesia risk? I would like to call upon our moderator, Dr. Raj Lokhida, head senior cardiac anesthesiologist of Arctics Kolkata. Raj Lokhi, please come.
And at the flag end of the day, I extend my gratitude and thank not to the organizers for inviting me, but to all those persons who still have the patience to stay back. So thank you all, everyone. And a very important topic that we are going to discuss on today. It's a very important topic. Is like, is it? Let me go. Is it ethical to proceed with elective cardiac surgery? Every point is important. To proceed with elective cardiac surgery in elderly patients with good prognosis, despite with high anesthesia risk. And to speak for the motion, I call on Dr. Ashish Chauhan. Please, Ashish.
Good evening, respected seniors and my dear colleagues. Today, I am standing here to present that it is ethical to proceed with the elective cardiac surgery in elderly patients with good prognosis despite high anesthetic risk. So, first of all, we'll start with the ethical pillars of the medical practice. There are 4 ethical pillars of the medical practice. They are the patient autonomy, beneficence, justice, and non-maleficence. So autonomy, every patient has the right to make informed decisions regarding their own body and health. So if an elderly patient fully understands the risks and benefits and still chooses surgery, respecting their autonomy is an ethical obligation, not an option. Beneficence. The principle of beneficence demands that we act in the patient's best interest. For many elderly patients, elective cardiac surgery provides relief from the disabling angina or heart failure, improved quality of life, substantial survival benefit. So, to withhold a beneficial treatment merely because of the chronological age violates the beneficence. Non-maleficence. So, non-maleficence is not only about avoiding surgical risk, it is also about avoiding harm from inaction. So, in cardiac disease, doing nothing may lead to progressive heart failure, recurrent hospitalization, sudden cardiac death. So thus, in many cases, not offering surgery may cause greater harm than the surgery itself. Justice. So justice demands fairness and equality. Denying surgery solely because someone is old is a form of age discrimination. If younger patients with similar risk profiles are offered surgery, then withholding from the elderly patient violates the principle of justice. So I'll come to the scientific and the clinical evidence by Garzon Rodriguez in an octogenarians undergoing cardiac surgery had similar complication rates to younger elderly patients, showing that high chronological age alone is not a contraindication. Lee et al. In this large study concluded that frailty, low LVEF, renal function, and comorbidities predict outcomes far better than the age. Meaning a physiologically strong 80-year-old has a better survival than a frail 60-year-old. Saha et al. This study on 688 octogenarians undergoing cardiac surgery found 1, 2, and 5 year survival of 75%, 72%, and 46% with excellent quality of life scores. So these results clearly show that elderly patients do benefit significantly. Then STS database analysis from 2020 to 2024 across thousands of patients models show that the high anesthetic risk does not equal poor long-term prognosis, especially when modern perioperative care is used. With the beyond evidence, the modern medicine has significantly lowered surgical and the anesthetic risks, like modern anesthetic techniques, which include intraoperative T, goal-directed therapy, lung-protective ventilation, then real-time hemodynamic monitoring. So these technologies have reduced perioperative risk dramatically, even in the high-risk elderly. Then minimal invasive and the enhanced recovery pathways. Minimally invasive cardiac surgery reduces the surgical trauma, blood loss, and recovery time. So enhanced recovery protocols shorten the ICU stay and lower complications. For the preoperative optimization, with better control of the renal function, anemia, nutrition, and pulmonary rehabilitation, elderly patients now achieve excellent postoperative outcomes. Then good prognosis is a good surgical candidates. So this motion emphasizes elderly patient with good prognosis. So who are these patients? These are patients who are non-frail, have controlled comorbidities. They are cognitively intact, have strong family and social support. So for such patient, surgery is not only ethical, but it is beneficial, appropriate, and life enhancing. So people may argue what can be the things like if elderly patients have high mortality. So my take is that the mortality is acceptable and often is similar to the younger cohorts where the frailty is low. So studies show meaningful long-term survival and functional benefit. Then another argument can be the anesthetic risk is too high. So the risk is not a barrier. Risk is something to be managed. With T, advanced monitoring and improved teamwork, outcomes are significantly better than they were a decade ago. Then some may say the quality of life may not improve. So multiple studies have demonstrated substantial improvements in the symptoms, independence, and physical capacity. Some will say the cost is not worth it. But my take is elderly patients with good prognosis often return to their independent living, reducing the long-term healthcare and caregiving costs. So it is unethical to place financial value over human life. Then the ICU burden is high. So modern ERAS pathway and minimal invasive reduce ICU stay, optimizing the elderly patients frequently have short, uncomplicated ICU outcomes. So my question is that it should not be whether the drug or the anesthetic risk or the age of the patient which matters. The question should be does the patient have a good prognosis, the capacity to decide and the potential to benefit? If the answer is yes, then and the evidence overwhelming shows it is both ethical and necessary to offer elective cardiac surgery. Denying surgery due to age or perceived risk contradicts the autonomy, beneficence, justice, and modern scientific understandings. These are my references. Thank you.
Speak against the motion, I call Dr. Obiji Kormukar.
I think
Good evening, respected seniors and dear colleagues. My topic is it ethical to proceed with elective cardiac surgery in elderly patients with good prognosis despite high anesthetic risks? The core ethical question, should surgeons and anesthesiologists proceed with elective cardiac surgery in an elderly patient with high anesthetic risks, ASA grade 4, paralytic, organ dysfunction, even when the surgical prognosis for cure is good? Our stand, it is not ethical. It is not ethical to proceed with elective cardiac surgery in elderly patient with good prognosis despite high anesthetic risks. Today I rise to speak against the motion because at the heart of the ethical medicine lies on timeless principle. First, do no harm. When an elderly patient carries high anesthetic risks, this principle becomes not a suggestion but a moral boundary we are ethically bound not to cross. The ethical medicine cannot ignore non-maleficence. Let us begin with the cornerstone of medical ethics, non-maleficence, the duty to avoid causing harm. High-risk elderly patients have reduced physiological reserve, higher chances of intraoperative instability, increased likelihood of stroke, renal failure, delirium, high risks of prolonged ventilation, tracheostomy, and ICU stay. These are not theoretically risks, they are real, common, and devastating. When harm is predictable and surgery is elective, proceeding is not ethical purge, it is ethical negligence. Beneficence requires benefit to outweigh suffering. Beneficence does not mean doing everything possible. It means doing what is genuinely beneficial. In many elderly high-risk patients, recovery is slow and painful. Independence is often lost. Functional decline is irreversible. ICU complications outweigh the surgeon benefit. Quality of life may worsen after surgery. What is the use of surviving the operation if the patient loses their mobility, cognition, dignity, or independence? A cure that leaves a patient broken is not a cure, it is cruelty justified as treatment. Autonomy is meaningful only when patient truly understand risks. Our colleague on the other side may argue patient autonomy, but autonomy is valid only when understanding is full and unbiased. Most elderly patients are dependent on families for decision, may not grasp the depth of anesthetic complication, have cognitive decline, or fear influencing consent, hold blind faith that surgery will fix everything. When comprehension is impaired, autonomy becomes an illusion. Ethics demands protection, not blind acceptance. Frailty is a stronger predictor than prognosis. Frailty is the real enemy, not age, not valve disease, not coronary blockage. A frailty index more than 0.25 leads to sharp rise in mortality, prolonged ventilation, failure to wean, higher infection rate, longer hospitalization, permanent loss of function. Frailty converts a good surgical prognosis into poor human outcome. Ignoring fertility and pushing aside is not ethical, it's reckless. Elective procedures must meet the criterion of acceptable risk. This is not an emergency. This is not life or death in minutes. Elective surgery, by definition, require acceptable anesthetic risks, acceptable post-operative burden, acceptable likelihood of meaningful recovery. If this cannot be granted, the ethical choice is not to proceed. Choosing to operate despite unacceptable risks is choosing to gamble with patient life. Quality of life matters more than length of life. Prolonging life is not the same as preserving meaningful life. Post-operative realities in this population often include delirium, cognitive decline, physical dependence, repeated readmissions, loss of personal dignity. Ethics is not only about years added to life, but life added to years. If surgical journeys inflict suffering, fear, dependence, and loss of dignity, then it fails the ethical test. Justice and resource allocation must be honest, not emotional. Ethics also demands fair distribution of healthcare resources. One elective high-risk geriatric cardiac surgery may consume precious ICU beds, prolonged ventilator hours, blood product, nursing, manpower. Meanwhile, younger or moderate risk patient may be waiting with better outcomes, less resource use, and greater benefit. Ethics require rationality, not emotional decision making. Real cases tell a warning, not a victory. Let me share what we all see too often. An 84 years old with a good surgical prognosis underwent valve replacement, post-operative delirium, kidney failure, 18 days ventilation, walked into the hospital but never walked out. A 79 years old with CABG indication but high anesthetic risks and fatality, developed stroke, prolonged ICU stay, become bedridden, family regretted consenting. These are not an exception. They are common outcomes in high-risk elderly surgery. Ethics is not a build on a rare success, it is a build on predictable patterns. These are the studies that cardiac anesthesia and surgery in geriatric patient, epidemiology, current surgical outcomes, and future direction. In their study, advanced age is still viewed as a relative contraindication to cardiac surgery. The significant improvement in operative outcomes in very elderly patients combined with increasing the recognition that more sophisticated markers of fatality, their age in isolation predict adverse result after surgery, mean that this viewpoint is changing. Very elderly patients therefore continue to make up a growing proportion of the cardiac surgical population. A clear understanding of the impact of age on perioperative management outcome will be increasing important to clinicians involved in their cares. Another study that anesthetic geriatric evaluation to guide patient selection for perioperative multidisciplinary team care in cardiac surgery. They concluded the addition of perioperative fatality characteristic to multivariable model improve discrimination between elderly patients with and without disability at 3 months after cardiac surgery and can be used to guide patient selection for perioperative multidisciplinary team care. Conclusion: why we oppose the motion? elective surgery in a high risk elderly patient is not just a medical decision, it is a moral responsibility. And when the risks overshadow the benefits, when the suffering outweigh the relief, when independence is traded for dependence, and when dignity is sacrificed for survival, it is not ethical to proceed. To choose and maleficence to protect dignity, to ensure beneficence, that is true ethical medicine. Thank you.
So may I go back to your slides? Because there is a single bed in your hospital which has been occupied. There is no ICU. We might have dearth of beds, but that doesn't deny a surgery because because at the cost of precious ICU bed, prolonged ventilator hour. I don't think that is the reason. Second, going back to your slide only, you said that 79-year-old patient with CABG indication with high anesthesia risk developed strokes. Family regretted consenting. Family doesn't consent. For a well-sounded patient, adult patient, it is the patient himself who should understand the risk and should give the consent. It is still a relative indication as your slides indicate. It was an excellent presentation. Now, may I go back to 3 scenarios, 2 real life. I was doing my morning round some 2-3 weeks back. Rudranko was there. Rudranko was one of the speakers today. I came across one elderly patient, octogenarian. He had 3 episodes of acute coronary syndrome in last 1 month. He was admitted with heart failure. Directly from the ER, came to our ITU. Me, during my morning round, I asked the patient, কেমন আছেন খাবেন? বললেন আমি অপারেশন করাবো না, বাড়িতে গিয়ে নমাজ পড়ে, I quote unquote the patient, বাড়িতে গিয়ে নমাজ পড়ে খাবো. Post duty, I found the patient on top of the list, OT list. I asked the surgeon, sir, you're operating on this patient? He didn't want to get operated yesterday. The surgeon said, a senior cardiac surgeon said, the relative wants him to get operated. Hospital যখন এনেছি ডাক্তারবাবু অপারেশনটা করিয়ে দিন. He got operated, had a post-operative stroke, intubation, re-intubation, then the inevitable happened. So, this is a case of a frail elderly patient, didn't want to get operated. He was at the flag end of his ride. We only prolonged the suffering of the patient. And please understand, this is a real scenario which I faced within a month. So, a frail patient who is not consenting to surgery, whatever the risk, whatever the good outcomes be, we are not in a position, the family should not give, they are not in a position to give consent for an adult patient who is capable of making his own decision. Pardon? Composement. Second, my own relative, somebody from my in-laws side, he was having chest pain. He was 72, 73 years old, quite active, used to do daily activities, used to live in some of the outskirts. Started having exertional angina, uncle was doing pretty well. There was severe calcific aortic stenosis. He denied surgery. Nana, বুড়ো হয়ে গেছি অপারেশন আর করাবো কি করে? Gradually, EF started decreasing. Over the next 2 years, 2 to 3 years, he started having dyspnea on exertion. The disease progresses. Now, when it was he was symptomatic, he gave consent for surgery. The ejection fraction, which was once a good fraction, has dropped down to 20-25%. Along with coronary angiogram was done. He has 4 targets. We were not in a position to operate him. So, a well-sounded person denied the surgery, didn't understand the risk of not getting operated. This was a surgery when he was first picked up. This was a surgery which, as we all know, a good ventricle patient, a preserved ventricle patient having calcific aortic stenosis, they have good outcomes. And a patient who was physically all right, he was doing all his daily activities. He used to go out, work, do his morning rounds. And third, we have all come across patients, octogenarian working out of the ITU, waving goodbye, and the nurses say, so, are you able to understand Bengali? So we have all come across this kind of patient. So, I would like to say whether to get operated or not to get operated should be the willful decision of a person who is sound enough to understand the consequences of not being operated and the benefits of getting operated, the risk of the surgery and the anesthesia, and he should be able to take his own decisions. In the modern era of advanced surgical and medical and advanced surgical and anesthesia management, with all that we have read, the goal-directed intraoperative TEE, post-operative better ITU care, are we really in a position to take the decision? We have this habit of taking decision for others from our childhood. But now this is the era, probably we should grow up and allow us, probably if he understands, we should clearly tell out, see, these are the risks of the surgery and the anesthesia. This is not a fairy tale picture, sir. And if you get operated, you will get this. If you don't get operated, the disease will progress, and at a time when you might consent for operation, it might be too late. So, in the current scenario, with all the modern treatment facilities we have the minimally invasive, we have the short-acting, ultra-short-acting, pain management, robust ITU care. Are we really in a point to deny surgery to a patient who has a good prognosis simply because he is frail? Thank you. Any other questions?
I think I'll talk to both these speakers, particularly Ovail and Rajulki also. I think we have slightly deviated from the topic given here. If I read the topic, is it ethical to proceed with elective cardiac surgery in elderly patients with good prognosis despite high anesthetic risk? Sanity is not anesthetic risk. By anesthetic means something else. Other organ dysfunction, poor organ reserve, and all these things in an elderly who has a different physiology. Okay. So whether probably this topic wanted to say that being an anesthesiologist, you know that basically other comorbidities, other risks, maybe gross CKD, liver dysfunction, or some cognitive dysfunction, multiple risk anesthetic means by what we mean by that. Whether you are happy to give anesthesia or whether you will deny anesthesia or whether you go ahead happily. I think we have slightly deviated from the topic. Sanity and all things, all these things will come later on.
I would disagree with it. I cannot move with anesthetizing an elderly patient without understanding the frailty of the patient, because frailty is itself a risk factor for post-operative morbidity and mortality.
Yeah, absolutely, I agree. Frailty is
Since we are talking about our senior elderly patients, we cannot just get away not assessing the frailty, because it has a serious impact on the post-operative morbidity and mortality. It is an independent risk factors. So we cannot get away.
Absolutely agree. Frailty, deconditioning are risk factors for any patient. Even a 56-year patient with CKD coming.
Correct. Even a 35-year-old female coming with the microsurgery.
Elderly patient with high anesthetic risk. Probably, I mean, slightly different what you expected in the discussion. And obviously, regarding that, we have got, for example, said MICS, we have got minimally invasive surgery. If the patient is functional capacity is the most, if the patient is functionally active, if he is willing to have even 3-4 years of life, you better give a chance.
Correct.
And
exactly.
Patient takes decision, not candidate process.
So I would like to give two examples. Like in our setup, we had two open areas. One was having acute aortic stenosis. He was an elderly person who was having an issue that he was a singer actually. He wanted to just sing. The only problem which he became was, will I be able to sing after the surgery? So that aortic valve replacement has been done. Patient was discharged and he went happily. And the other patient is one boxer. I think it was some coach was there. So he also came with the same thing, like he was telling me, see, you were asking me the question of frailty. I was doing the PSC. So I asked according to frailty score. Then he told me, why are you concerned about my age? See, I may be over 82, but if you see me, I'm much more healthier than a 40-year or 50-year. So why I should not get operated? He got operated for CABG and again he got discharged and led a life. Although in post-op, we couldn't, after many days of once discharged, we couldn't find out how his life has been there. But definitely he was happy, then we should definitely go for the patient's condition if he wants to get operated. And if we see, yes, he is a good candidate, then we should go for the operation.
And here comes the importance of the surgery.
Correct. We only talk about
any sternotomy, even a hip fracture, any bone injury for an elderly patient is very dangerous. So in that case, minimally invasive gives excellent result. We have done many cases, 85, 87. We have done 91-year-old MICS patient that's gone home. Only thing, if you can maintain them in sinus rhythm, that's the key. They go into air, we have seen. You just trust it.
So in the modern era of minimally invasive, as Dr. Manali said, with endoscopy, there is no point. If your institute has this facilities, really, I don't think there is a
need of prognosis. You are expecting good prognosis, then age should not be the criteria.
Age should not be the criteria, rather the frailty, the functional outcome, the functional capacity of the patients. It is like we are doing aortic. We have been talking about the aortic stenosis. We are doing TAVI in case of even very elderly patients with comorbidities with reduced. And we don't give anesthetic. We don't even nowadays give general anesthesia to all patients. They are a risk factor. They are being done under monitored anesthesia cases. We have been doing cases with good outcomes.
Definitely. Just to add one thing, from a medical legal point of view, you have to take consent of a family members. From 18 to 65, it is not needed. After 65 years, more than 65 years age, you have to have a consent from a family member too, along with the patient.
So this is about the caregivers in the post-operative period.
No, it is a relative of the patient, any family member.
Because somebody has to look after the patient in the post-operative.
Yeah, that is the reason.
A patient just cannot walk in and get operated and walk. That is for any.
So that age limit is mentioned in our code of law. That if it is he is like a physiological age is 40 years, but his actually age is 80 years. We have to take a consent from his
That there is
family
some,
members.
yeah,
Yes,
that's it, there is some
That's
support, family support when he goes back home.
Yes, definitely.
Many times it happens, we take consent from only family members. The patient gets backstage. Nobody, even if patient doesn't want surgery, family members are pushing, then it can be operated. It's sometimes patient's own opinion.
This is the real life we have been used to. ছোটবেলায় বাচ্চারা কিভাবে কি পড়বে মা ডিসিশন নিয়ে নেয়, বড়বেলায় বাবার অপারেশন হবে কি হবে না ছেলে মেয়ে ডিসিশন নিয়ে নেয়।
What is your opinion, conclusion? That is what to be done. Ashish, Abhijit?
Point of view, I think we should not operate the patient with the age above like the 65.
Physiologically, you're talking physiologically.
Yes, yes. Is a more than 65 years old at that.
Their patient পাবে না।
80% of patients continue more than 65.
And for aortic surgery, more than 80 years.
There is
Rehabilitation.
Oh, that is the thing, that the willingness to do it. If the patient himself has not consented, he has been not a prime member of the decision-making team. Post-operatively, he is not going to cooperate. He's not cooperating. That willingness and willpower has to be there. And this is only, as the Farooq Pratham, is only a part of our discussion. The main thing is the frailty, the high anesthesia in this. But with the current era of the modern anesthesia, with the MICs, I don't feel that there is any point in denying surgery to a patient if there is a good surgical outcome. Thank you.
Respected seniors, my esteemed speakers and distinguished colleagues, my juniors, my dear friends. As we come to conclusion of today's session, with our hearts filled full of learning, reflection and gratitude, what we witnessed today was not just a debate, but a collective studying, collective journey of thought, ideas were exchanged, beliefs has been changed, perspective has been widened, and all with dignity, humanity, and respect. This is the true essence of today's academic growth. So medicine has always evolved with the questionings through the courage to ask why. And sometimes even more importantly, why not? So today's discussion reminded us about the change of clinical practice is not merely a technology, guidelines, or a statistics. It is all about the patient outcome, patient compassion, and responsibility. So some arguments today has defended the tradition, others advocated some transformations, but together we created a balance because the progress never requires abandoning the past, it requires building upon it thoughtfully and with responsibility. So to our distinguished speakers, thank you so much for sharing your wisdom, clarity, and generosity and sharing your experiences. Your words will stay with us long after the hall becomes silent. So to all participants, thank you so much for listening and with an open mind and participating in our discussions with grace. And academic cultures grow only when the knowledge and the humanity grows together. And today, that is the spirit has been clearly visible to all of us. Let us carry forward not just with the points debated, but the mindset that we cultivated today. With a mindset of curiosity, reflection, and willingness to adapt the betterment of our patients and for all our practices. With a deep respect and gratitude, I would like to thank all of you for being a part of this debate. Wishing you all the safe journey home, and thank you very much for patient hearing.
I have also this. Thanks.
On behalf of WB ACTA, I would like to thank everyone. Dr. Mona Lisa for curating this debatable subject nicely and contacting all the speakers and moderators and all the people who are connected online. Stay connected and make this discussions vibrant. So I would like to thank everyone for being here. Thank you, everyone. We'll meet again in some other discussions.
Thank you. Thanks for coming to our home. Thank you.
Thank you.
It is fine. Okay. Okay.
আমি ওটাও লিখেছি এসকেলেটরটা ঠিক রাখি আমি যখন যাবো আমি যেতেই থাকি করে বাচ্চা বসে ওকে নাইস
Only noise. Okay.
ঠিক আছে ঠিক আছে ফোনটা তাহলে ও প্যানেলে দিন আর কাউকে নেবে সব রেডি তুমি রেডি হ্যাঁ কিतना है आपने आज कौन নষ্ট হয়ে গেছে সামনের বছর সামনের বছর আরেকটা সামনের বছরটা
স্যার লিড করে দিলাম
ঠিক আছে দিয়ে দিলাম চারটে হয়েছে